That was fun. I'm not sure how. I'll see
She said that they received it, so I can check.
Okay. Yes, because it's not here.
Are we ready to go?
Yes, okay, so let's get it turned back on here. Okay.
Good morning, everybody. Good morning. Welcome to this annual scientific meeting, the Neurological Orthopaedic Surgery Part 2. Our session runs technically to 10, but we have room to go over, and in that vein, we have our first presenter, Dr. Gragnaniello, who's going to speak twice. And I think it's prudent just to have him follow himself. We are going to make room for questions immediately afterwards, should you have any. And our first talk will be on the modern management strategies of thoraco-lumbar trauma with Dr. Gragnaniello.
He was just here.
Dr. Gragnaniello.
Yes, sir.
Yep, I just announced your first talk. Would you like to do both your talks back to back?
However you prefer.
Let's go back to back. We'll take time for questions in between.
Okay.
All right.
All right. So maybe I think she's doing the other one now, fresh it up.
She told me it was already looking at the first one. I think it's, but by the time you're done the first
Oh,
one.
yeah.
And if not, we
Nice to meet you. I'm Sudhir. Nice to meet you.
So I've got a microphone for you.
Again, Dr. Gragnaniello's first talk will be on the modern management strategies of thoraco-lumbar trauma. The second talk will be on the perioperative planning of MIS techniques to improve outcomes in spinal deformities. And we'll take a break after this first talk for questions. Pursuant to the first one.
Thanks for having me here. It's an honor and a pleasure to be in front of such esteemed colleagues. And these are my royalties, which are not relevant to this talk. So I'll bring you through a very short journey around, how we get to treat thoraco-lumbar trauma the way we do now. And this is all very important because thoraco-lumbar trauma is very common. It's represents 7% of all bronchial trauma. There are about 200,000 spinal fractures in the US, 25% of which are spinal cord injury, and because because of the special anatomy of this region of the spine that goes from rigid to very mobile, flexible. And as you all know, this is a little bit of a representation where from T1 to T8, we have the rib cage, everything is quite stiff, and then we've got transitional anatomy from T9 to L2, and then very mobile, and from L3 to the sacrum. And for the longest time, and we'll see it's been over 100 years, we've been classifying and trying to classify thoraco-lumbar trauma. And why this is important, it is because we need to be able to communicate to each other what's going on in the middle of the night when you get a call and decide if you need to come out of bed, get out of bed and cooperate, or wait and sit on something, do something, do nothing. And also, it should assist you in deciding what to do, and you should be able to know what you expect as an outcome from whatever treatment you may decide to do. And all started, around the 1930s with Sir Watson James, and we have so many classifications, and each one has been different, and we'll see in a moment what they brought to the table and how it improved our understanding of this complex issue. And why so many? Well, we still probably don't have the perfect classification, to be honest, but a good classification should be having validity, reliability. So when I look at the scan or hear about the patient, should be able to agree with the next person that looks at that scan or hears that story. Should be accurate, should leave no ambiguity, should be easy to use, and then should be including morphology of the trauma, what we see on the scans, and also should be related to the biomechanical mechanism of injury, and most importantly, should tell us what the patient looks like and what's their neurological status at the time. And this is a little cartoon that kind of includes all the classifications that have been done so far, and how they add to each other. But starting back in those days in the 1930s, so Wilson James started observing about 250 fractures and divided them in 7 types based on their morphology. And here we have the first definition of simple wedge, comminuted fracture dislocation. Interestingly, all those fractures were treated in hyperextension cast at the time, but the dislocations were reduced with surgery. And then Dr. Chan's, one of the most famous fractures, the flexion extension injuries that consist of a horizontal split of the neural arch. Then we go to almost to the 50s with Dr. Nicol that essentially put together the 2 classifications and did some extra work on these. And it's the first time that somebody is really interested in outcomes, and essentially it was in a mining town, and so the perfect outcome for him was that the patient was able to resume mining work. And I find that to be very interesting. And so, and this is also the first time that somebody described the fact that functional outcome is not tied with lack of deformity. So even people that had a persistent deformity on their scans, they were still able to go back to full work and be free of disability. Obviously, at this time, all we have is X-rays. And then we get to the 60s with Holdsworth, that essentially is the first one that divides anterior weight bearing part of the spine with posterior tension band. This is one of the fractures they describe called the slice fracture. Again, as you see on the right side, the different mechanism of injuries, really, we're still looking at this through how did this happen. And at the end of the 60s, again, we had a 2-column representation of the spine essentially, with one part being the vertebral body and the other part being the canal. And most treatment fractures were treated essentially. If they were unstable, they would be treated probably with a rib graft and an anterior approach to provide anterior support. And then we finally get to the 80s when the colleagues from 2 become 3 with Dr. Dennis. We're all familiar with this and what it means. So finally, a lot of emphasis on the posterior ligamentous complex, which will be so important down the road. McAfee is a very important classification as well. It's the first time that somebody speaks about a burst fracture and classifies a stable burst versus an unstable burst. Ferguson and Allen, again, mechanistic classification to clarify the pattern, and I'll be skimming through this, just putting some emphasis on McCormick and Gaines, and then describe the mechanism of convolution. And this is the first time that somebody actually brings deformity and kyphotic angles to the table, making this an important point in deciding what to do. And then we get to the 90s, where we had an unbelievable classification from Dr. Marker of the AO spine that was very comprehensive, to the point where it had 53 types that people would be disagreeing on what the fracture would look like, and it would be very difficult to have 2 people to agree on some of these fractures. And so, very comprehensive but difficult to use, so not so useful. In 2005, Dr. Baccaro and this group, a group of surgeons from the state, put together a great classification that's TLX, that's based on morphology, integrity of the posterior ligamentous complex, and neurological status. If you had points that were 4, less than 4, you would be treated conservatively. 4 would be surgeon choice, and more than 4 would be certainly treated surgically. But again, here we kind of know what to do, but we really don't. We don't know what kind of approach we should be using for those that would be surgical. And so at this point, CT is used mostly, and it's difficult to look at the ligamentous complex at times on the CT alone, and just know if there is an integrity or not. And so not every place has an MRI, and so that makes it kind of difficult at times to decide when to operate on somebody. At this point, we need something different. So the AO spine and TLX kind of merged, and I'll just skip through these and how we got there. There were experts from across the globe that came together and agreed on looking at fractures and defining them. And at this point, there was an injury score that came out, but again, no recommendations on how to treat or what to treat until we get to the TLAOSIS in 2015, when we divide fractures again based on morphology, and we get more data, and that's something easier to follow. Essentially, we look at the morphology, and we get points, you get neurostatus, and you get points, and you get some of the modifiers that may allow you to include or exclude a patient from surgical intervention. And then again, you sum it all together and get to a decision. So again, we should have a classification that should be simple to use, include most of the injuries, reflect the mechanism, and allow you to determine treatment options, determine prognosis. And so how do we treat after all these? We talk about fracture. Well, compression fractures, we know that we used to brace a lot of these, and there is data now that I'll show you that tells us that probably we shouldn't really be bracing as much. Makes us feel better, probably not really necessary. Stable burst, we brace just a few, and surgery only if they have multiple injuries, happens at times, like on this CT on the side, you see there are two burst fractures. We end up treating them, otherwise we treat conservatively. And this is a paper from the WFNS Spine Committee and the recommendations that essentially defines the treatment goals of all these, which, as you know, that prevent further neurological deterioration, promote neurological recovery, stabilize the spine when it's unstable, restore alignment, and mobilize patients early because we know that they all do better, and minimize pain and deformity because these can be actually reasons for surgical intervention by themselves. So do we brace them? There's a systematic review from Gill et al. Essentially shows that there's really no efficacy in bracing. But if you decide to brace somebody, they're probably patients that are intact neurologically. They have less than 40% of weight loss in their fracture, and the people that can be compliant with this. And looking at kyphosis, there should be 10 degrees or less. If we have an unstable burst, anterior corpectomy is probably something we're going to get to, and to support the anterior column, and this can be done with grafting and posterior instrumentation, especially for spinal cord injuries or high level of gains convolution. If we don't have much convolution, posterior approach alone may be actually beneficial and simpler and with less comorbidities. Things to consider when treating thoraco-lumbar fractures are pain scores. For example, stable burst, we tend to treat those that where pain is an issue. Once they stand up and you get images that show stability of the fracture, but they're still in pain and severe pain, it's difficult to control over a few days. We end up operating on those. The kyphotic angle is something interesting. It's been found that if it is up to 30 degrees, actually it does not correlate very well with pain. So you may have 30 degrees of kyphotic deformity and very little pain. Surgery is better, obviously, as you can imagine, at decreasing this kyphotic angle and maintaining the vertebral body height. In terms of quality of data, surgery versus neurosurgery, there's conflicting data, and we still don't have a very good study to demonstrate what's the best treatment. In terms of length of stay and return to work, again, depending which paper you read, people seem to go back to work right away, or the other work forever, so not very clear. Some things that one can do in these cases, anterior constructs or with very short posterior instrumentation, and that's kind of a great way to approach these. But when you have more complex fractures like flexion destruction injuries, we mostly treat these posteriorly, 360 degrees only when there is severe canal compromise or you cannot achieve enough decompression from the posterior approach alone. Fracture dislocations, mostly 360 degrees. If they're complete injury, chance fracture, we all treat those posteriorly alone. And this is where a great advancement has been done in the last decade, where we treat most of these percutaneously to provide fixation. Interesting techniques coming out. This is from Dr. Anderson and his colleagues, where essentially you're able to reduce a fracture dislocation by just manipulating the rods horizontally. I think that's a great adjunct. Gunshot wounds are so common these days, unfortunately, and proven not to be treated with surgery, and there's a lot of literature on it, unless there is a bullet that's completely in the canal and that there is data to suggest that there is a neurological recovery. So when we look at anterior versus posterior instrumentation, at this point we know that they're kind of equivalent terms of outcomes, long term. There's a tendency to have less kyphosis and better pain and function when you actually have the anterior column support. Able to do more motion segments with anterior procedures, but this is not the improvement to date. Some of the hurdles and things to consider is that if you have more instability of deformity or good bone quality, you might have to go longer. You need more points of fixation. Sometimes you're going to need anterior column support, especially you're going to have to go longer in cases where you have ankylosing spondylitis, or dish, RA, where the patient is osteoporotic. You might have to add cement or malnourished, same thing, so you end up with longer constructs. In conclusion, what we really need is uniform language to define these lesions, have a plan, stabilize the spine. You can always do more later, especially in those cases where you think you may need anterior column support, but the patient is so sick from other injuries that happen at the same time. It's a good idea to start posteriorly and see if you need more. And obviously, work with your hospital to have an excellent trauma service. Thank you.
Any questions?
Yes, sir.
Timing. You decided you're going to operate on when was the
So,
body?
so literature say, if it says that it would be the first available opportunity, and that usually is quite early in the trauma once the patient is stable. For any trauma, it's ABC first, and looking at the stability of the patient if they can go to the operating room. And sometimes if that happens early and then other comorbidities take over and you lose your window of opportunity. So I think that it's the first available opportunity once the patient is stabilized, the ABC is taken care of.
Is a CAT scan sufficient for detecting posterior ligamentous complex stability?
It is so. It is most times, but T2 stir. Sometimes, if you have availability of an MRI, just run a T2 stir, just that sequence. It may take 10 minutes, and will just in cases that you're in doubt. I think that's a good idea.
When you say just that sequence, you mean just the thoraco-lumbar region?
Yes, yes.
So what if there's an associated injury? I read that there's 25%, readings accurate, associated injuries in another region. Do you routinely do an head-to-toe scan or predicated on physical exam?
Yes, so physical exam, one thing I tell my residents and everybody that's involved in this type of care, they should always roll the patient and look for any steps in the back, their fingers down the spine, do a thorough exam. And then the CAT scan gets done tip to toe, always. In every trauma patient, there's a trauma survey kind of CT scan that they get.
Is my remembrance right? Is it that high, 25%?
It is true. It is true. There's tandem lesions more often than not.
And they require surgery. What percent of those require second or concurrent surgery?
It actually, surprisingly, is not that high. Just in the last year, the times that I treated, like say, I've done recently a cervical and a thoraco-lumbar, it is probably 1 in 5. Something like that. In my experience, for what I read, so 25% is probably true.
Is the postoperative complications that are non-musculoskeletal, are they proportional to the rating systems? The more severe trauma, the more likelihood for respiratory trauma, respiratory failure, concurrent kidney injury. One would think there would be. We have a patient who has a thoraco-lumbar fracture now, conservatively managing her acute renal failure, intubated, with a fairly minor fall, a frequent fall.
Yes. So what we've noticed is that as age increases and comorbidities increase, then you're going to unfortunately have worse complications in patients that don't necessarily have such severe injury in their spine. But to your point, at times people have prolonged ICU stay even from after mild trauma, and going back to the timing, in our experience, I mean, we had some great results, going from Asia A to even D or E when we are checked in the middle of the night, which is probably anecdotal, and patients have been saved, spared probably from other complications, but the most frequently seen is certainly the thoracic respiratory complications. We have a ton of patients that, especially in MVCs, they end up with contusions to the lungs, and they stay intubated for a long time.
So then, last question for me is that I have a patient with a T12 compression currently and a T11 spinal process fracture. Inherited him as a second opinion from the insurance company, it's workman's comp. The likelihood of him getting back is low, I get that, but he's painless. He just has limited function and wants to get back. I don't want to assume liability for a patient that I didn't initially manage, nor would I for what I do. What type of long-term follow-up do I give this fellow who says he's painless, has some range of motion limitations and lateral bending only, wants to get back as a roofing inspector, but I don't want to assume liability in getting him back. He's got an FCE and it says he can run, heel bend and crawl. But if he has long-term failure, how do I monitor that? What's our responsibility to follow these people long-term? Not just in the workers' comp setting, but in an ethical setting. How do you deal with somebody 6 months down the road that you can be stable?
So my practice has been, and currently I think one unacceptable practice is to follow them as patients you would have operated on with X-rays, standing always under load at 2 weeks, 6 weeks, 3 months, 6 months, a year, and then 2 years. And there will always be standing scans, and I will always get a scoliosis scan just to look at their overall alignment if there is any kyphotic deformity. Because at that point, what you may find is that in a patient like that, 6 months down the road, they might start to kyphose, or 3 months down the road, and that would be their major issue. But if the fracture is stable and there's only lateral bending, obviously you wouldn't do any surgery. I think it'd be safe to follow. I see your point of not taking liability for that. It's probably safe and you're fine, but I'll keep following them up to 2 years.
Up to 2 years, yeah. One last question. Do you have disc-based collapses or known diagnosed ligaments injuries in patients without fractures? Hematomas for patients without fractures?
Yes, so yes, absolutely. And in those patients, I think the first thing would be the exam, the neurological exam, will tell you more, even in absence of lesions that you can see on a CT necessarily. But on a CT, you'll see blood, you'll see probably disc, and that would guide you to get a more in-depth exam than MRI at that point, which should be done immediately and even in the middle of the night, especially if the patient has neurological compromise.
I have one question. So if you decided to operate on an unstable fracture with neurological injury, you fix the fracture with posterior instrumentation or whatever, is it necessary to also decompress at the same time, or will the fracture reduction itself be adequate for neurological decompression?
So when you have a fracture dislocation, you most likely do this open. Like in case of a chance, I would do this mostly per. But in case of a fracture dislocation, I'll do this open, and I would only decompress if my say you either use shunt screws or whatever technique you like to use to reestablish the alignment. Once you reduce the fracture, your post-op X-rays or intra-op CT scan will show you how much of the reduction you got and what's the canal compromise at that point. At that point, I had a very low threshold to do a laminectomy and just make sure that everything is free if I'm not convinced that I got a very good reduction. And that's happened to me, especially when I had concomitant and fractures that were like the issue I showed was keep level, and at times it's very difficult to reduce completely. At least one of them, you don't get great relief from the pressure of the canal, and then I would open and use instruments that you would use normally for deformity or PSOs to tamp down the fragments. That's another thing that I found to be useful, to distract and push down and allow the metatarsus to then keep those fragments down. That's one thing we've been doing. It's been working well.
Thank you. Any other questions for the doctor's first talk? We'll continue now with the second talk on the perioperative planning of MIS techniques to improve outcomes in spinal deformities.
In this talk, we just discuss some of the nuances and things that are happening. It's a great time to be involved in spine surgery. It's such a young specialty, and it's advancing so fast. Our knowledge today is not the same as it was 5 years ago, 10 years ago. And we're doing bigger surgeries and treating very complex issues with far less tissue disruption and comorbidities. And so, in our evolution as spine surgeons, it is my opinion that we should try and keep learning. This is lifelong learning, and so improve our techniques and evolve. And so it is not uncommon today to go to the office and your first patient puts your graph and they tell you that they have neurogenic collocations of pain in one leg, and you look at their scans and yes, they have stenosis, but they also have deformity. And so, what to do at that point? It's complicated. You may decide to just do a limited decompression and watch them, or you may decide to address their whole problem. And so there's a lot of effort that goes into understanding what's the right thing to do all the time. So is decompression alone going to be enough? Is it going to be durable? You're just going to do the symptomatic level or more levels, and you're going to treat their sagittal, their coronal imbalance, and how. And so there's a push for trying to do things that historically have been done with big surgeries and big open surgeries in a more minimal invasive way, which we'll see what it means. And so there's this misdev where essentially you're trying to look at finding a way to define which lesions you should treat and how. So looking at sagittal and coronal parameters, trying to understand if you should just do limited decompression, maybe doing a fusion with resolulisthesis or doing more and more until you get to where you open surgery and osteotomies. And so if you look at these patients that I just showed you, they had a mismatch between their pelvic incidence and the lumbar lordosis of 30 degrees and their SDAs of 6 centimeters. So you might think that this patient is actually disabled, and you'd be right. And so at this point, it suggests that you may do a circumferential invasive approach with with PSOs or spinal cages or whatever it is that is your favorite technique to achieve that correction. And so, they prove that this is actually quite a good algorithm, and that you get good results even if you go small in terms of how you approach this. But it all comes down to why we do this and what we do. And so we perform a surgery to alleviate patient symptoms, and we want to optimize the burden of comorbidities. We know that many of these patients are frail. We need to understand these curves, and we should use models to predict our correction. And I think that's actually very important, and I'll show you what I'm doing these days. And also, consider new techniques that to indirectly decompress these levels. So one thing to be doing in every patient these days that comes to the office is to get a full skull X-rays and look at the curves, look at their spinal pelvic parameters, looking at their neck, and how these curves relate to each other. And that's important because it's been proven that when you realign people, and it's true, I've heard many times from the people that talk with spine surgery, that even if you do one level of surgery, you're either creating a deformity or you're treating one. And so I would take a patient and look at their spinal pelvic parameters, and then plan what I think the patient needs to achieve their balance and be in their cone of balance. And I would go as far at times as to pre-bend the rods. I get the rods bent on the correction I want to achieve. So then when I put the rods down, I know if I'm true to what my preoperative plan was. And this is an example of that. So I'm going to do an oblique lateral interbody fusion, and I'm going to get these 90 degrees. I'm going to do cuts, PCOs at the back, and I'm going to achieve this much and to realign my patient. This is a chin on chest deformity. I followed the same principle. It was fused and kyphotic at some levels in front of his neck. So we had dystonia. So very tough case. So again, pre-planning, I think we brought it back to where it needs to be. And so some of these techniques I was telling you about allow us to do more with less blood loss, less complications are some of the lateral techniques. And about a decade ago when I was in Australia, we started doing anterior to psoas or oblique lateral body fusions, looking at this natural corridor that is between psoas and the blood vessels anterior to the spine. And you put the patient in lateral decubitus. The advantages compared to what's called an extreme lateral X-leaf is that it's mini open. You don't need to monitor the patient. You have direct visualization. You get an incision that's a couple of inches in front of the two finger breadths, a couple of inches in front of the iliac crest, and in front of the anterior margin of the vertebral body. It's ideal at 4-5, while at direct lateral, it's very difficult to do, especially in males with a high pelvis. It's an approach that respects every muscle layer. You actually dissect the muscles along their fibers. You don't cut any of these muscles, and you get to the retroperitoneum, where essentially you go up and you dissect until you see psoas. Without cutting anything, you're just going to make sure that on your way in, you see your inguinal nerve, and to make sure that you don't, you see or don't see ureter, don't cut anything. Get down to the spine, just like in this cartoon, and you have this natural corridor. At this point, you just retract psoas slightly, protect your blood vessels with another blade, whatever retractor system or company you may use, it never changes. You may see sympathetic trunk running through, which you can take. The patient is going to have a warm leg for a couple months, and it's going to get better and resolve. Advantages are obviously you don't go through psoas, so you don't put at risk your lumbar plexus. You're not forced to place your cage wherever your lumbar plexus is not. So you can put your cage as anterior as you want and get as much correction as you want. You may cut the anterior longitudinal ligament if you need more. You can do a corpectomy if you need more. It's easy to see and take a iliolumbar vein if you need to. And so this is a little bit our sequence of events where we do a discectomy. These days there are some companies you can even do this navigated. So it takes away even the being taken up to the table with the patient and do x-rays and place your cage. And this is some of my own dissections where I show you this anatomy where you see genitofemoral nerve, which is very important. It's the only thing you're going to see on psoas, and you want to make sure that you save that. This is psoas at the back, and the sympathetic trunk is running across, as you see, and those are the iliolumbar veins. So, and this is what I was telling you about lumbar plexus anatomy through psoas. So as you go down the spine, the lumbar plexus moves, you're forced to put your cage somewhere in the spine where not necessarily it's going to give you the correction you need. And this is another study that shows where those nerves appear more frequently according to the spinal anatomy. And this is an example where I released the anterior longitudinal ligament to get an hyperlobe cage in there, protecting the blood vessels with the blade so that nothing gets cut. This is another cartoon where you see psoas, and it's a mini open, lots of space, lots of room. That's the iliac vein. And this is some cages inside. The psoas undisturbed. And you can cut just like you would do for an ACDF. You can cut and retract a little bit of it, nothing happens. And this is, if the video starts, I'll show you. And this is a video we published about a decade ago, so it's incisions have gotten much smaller since then. Well, it's actually on YouTube. If you go and do anterior to psoas, it come up. It's the first video.
Hi, this is Kevin Sticks. I'm going to talk to you about the ATP approach. The incision for this is generally in the line of the external oblique fibers, 4 or 5 level. It's about 2 fingers in front of the iliac crest between the ASIS and the umbilicus. This would be centered on the projection of the disc space as marked on the skin as shown. The approach utilizes the natural corridor in front of psoas and behind the vessel, so it's an oblique approach that allows us to be orthogonal to the spine, and this funny looking retractor is key to that because it allows us to work under the iliac crest. These tools are designed to also facilitate this. They allow us to work under the iliac crest but work at right angles to the disc space. This axis impression shows the amount of retraction of psoas. This is Kevin Sticks.
To speak up.
This is Kevin Sticks.
That's okay. So these are some examples of very collapsed disc spaces, just standalone. Again, you can see on the right hand side the CT. This is another standalone with a blade. At times we've been able to do 5-1, and I know there are some companies that are pushing further out what they call lateral healing. We've done it from the same approach with good success. And these are some recent cases where patients have been decompressed multiple times. Actually, this is a patient with a very young patient with a coronal deformity, which you find that this kind of deformity is really correct under your eyes when you come from lateral, and you see narrow congenital canal. This is the patient that's really off on the coronal plane. You'll see that he's got 60 millimeters of C7PL to the central sacral line, and he had a 5-1 disc that was good, and it's only 35, severely disabled with a cane, severe pain, neurogenic colligation that we brought back with just 3 level to 20 millimeters, which is the upper limit of normal, without having to do a kickstand rod or anything too invasive to him. This is a 64-year-old male that with neurogenic colligation, multiple decompressions, miserable, very impacted quality of life. He failed every trial, conservative treatment, and essentially this is his pre-op scans and post-op scans on the side. He went back to essentially full-time landscaping at 6 months. And 5-1 probably native most times. And this is a 75-year-old man that essentially was suicidal, gained multiple decompressions, followed him up for a year, tried everything else, and finally we decided for surgery. And essentially this is post-op, and 6 months later is medically because I still don't let it move, but kind of good result. And sometimes you don't need to take care of everything. You'll see that 12-1 over there, is fused essentially naturally, so I left it up. Didn't cross this thoraco-lumbar junction, didn't go up to the 10. That's it. Thank you.
Are there any questions from the audience?
Yes, sir.
When you use your approach, what number are you looking for the cage size to get indirect compression?
That's a very excellent question. I think it really depends on our preoperative MRI. I really spend a lot of time looking at the foramens, and as you know, the classification of foraminal stenosis, when I feel that the disc is impinging on the nerve root and going up, I think anything above 6 really. It depends where you place it. If you place a cage that's very anterior, and you may have to have more height at the back of your cage, so not use so many degrees of lordosis, but a bigger cage, and that's especially true even for the bailiffs. It depends where you put your cage, how big is the back. But I think anywhere around 6 millimeters will probably give you enough indirect decompression.
One follow-up. If you have any type of facet orthosis, the anterior approach, no matter how big of a cage you put in, can't move concrete.
Yes, sir.
So do you plan on doing a full vasectomy at one time to allow your decompression to actually work?
That's a great question. So the way I look at these, I look at preoperative scans and their sagittal scans and see how much of decompression comes from the facet joints and how much is not, how much canal stenosis there is from the back. And so I would put percutaneous screws to fix some of these where I think I can get away with the just indirect decompression if there is any impingement from the facet joint that comes from the back, and so even narrowing the foramen from the back and the top, I would actually do local decompression in the back.
At the same time?
Yeah, same time. I tend to, I used to stage these to see if people actually had residual leg symptoms, but it's becoming more and more difficult to bring the patient the following week to get their second stage, and so I ended up making an educated guess and say, we can always do more and do a midline incision for the decompression, or limited decompression if we need to.
Do you ever get in trouble with the arterial nerve injury?
I get to have a vascular injury. In the last 15 years, the only time I took the patient back was after a nail lift for a venous use, and the patient became orthostatic, and it's always retroperitoneal hematoma to improve it, but otherwise, it was taken back, they couldn't find anything, they just found some material and stopped. It was not probably used from a small vein. But I never had any vascular injury from a lateral approach, or at least not yet.
Do you routinely use TXA?
Yes, at any time, I do 3 and more levels, and I think I'm doing a lot of posterior work. I use TXA at lower balls and then on 4 milligram per kilo as a continuous infusion afterward.
Any other questions for Dr. Gragnaniello? Well, thank you very much.
Thank you.
Our next talk will be on post-surgical outcomes with interspinous spacers, lumbar spinal stenosis, clinical outcomes, and complications. Dr. Mohan.
Okay. You turn this back on.
What do they do?
It's out of this.
I'm going to talk about interspinous device, which actually is interlaminar fixations. There are tons of them in the market, and you all know you have tried this, you have tried that, and then finally decide what's good for me, and why am I choosing this over the others? All of these questions keep coming into your mind. My co-partner and my good friend Ramiro was supposed to be here, who is a great statistician, and he had put in lots of slides with statistics, which I took it off because I'm not a statistician. So I'm going to talk more on the technique and see what are the techniques we used, and was it all useful, or is there something that I did a little different, I modified a little bit, and that can help the patient. So those are the main concerns with which this presentation was put together. I don't have any disclosures. So, as you know, the evolution, from the time that from quadruped to standing on the legs, we are paying toll for everything that we do and everything we don't do. So it's like we are all like cars, you just buy a car, you come out of the dealer store, it gets depreciated. So we come out of the womb, we start degenerating. What an irony, right? So the real estate in the spine in any canal is like, that there's a disc in the front, you've got facets, and you've got ligament of plavum, and they all can be a participant in compression. And it's very, very difficult when my patient says, should I exercise a lot, or should I not do anything? Like you exercise, the facets become more and more hypertrophic. If you don't do anything, you become osteoporotic. So it's like, it's a difficult question. There are tons and tons of papers keep saying that, you strengthen your back muscles, you strengthen this, you strengthen that, but at the end of the day, somewhere down the line, you're paying a toll for what you do. So there are like lots of people who put in a lot of studies on the diameters of like cross-sectional diameter, anterior-posterior diameter, to say like when do you call this as a spinal canal stenosis. And over time, having done like 20-25 years of spine surgery, we all have realized that there are many things that play, and you can be born with the small canal, or you can be born with a large canal. If you have a big real estate, you can accommodate a lot more people into the place. Or if you have a small real estate, no matter what you do, it gets congested. So this slide is busy, but you can get a feeling of what is a congenital stenosis and what is an acquired stenosis, and what are the players there. And over the years, I mean, if you see our professors, they just did, especially the neurosurgical professors, they just did only laminectomy. They didn't want to do any instrumentation. They thought the patients would do fine. Don't worry about it. Orthopedics are crazy. They just put screws for everything. You don't need to do anything. So we all believed that for a long time. And then patients starts coming because these professors were not following them forever and ever. Then as residents, we followed our professors' problems. So they have some kind of a list disease, and then we gotta fix them. So all this was going on. And then in this slide, it shows that there is, again in the United States, there's a lot of controversies of who does what and what training they have gone through, who know what they do. So if you see the South and the Midwest, there's a lot more fusion rather than just doing a simple laminectomy. But again, this slide was developed in 2019. This paper came in 2019. From 2019 to 23, that map is totally different. There are a lot of people in New York, a lot of people in California putting tons and tons of screws and lots of fusions going on in this country. Is this CPT code oriented? Is it market driven? Or is it all money? Or is it reality? So all these factors have to be addressed. And more we do complex, more we do lots of fusions, patients will not have a great quality of life. Like you might have done a perfect picture, perfect fusion, but patient is like a robot. He's just walking like this in the room. Is that what you wanted? Or after you fuse, patient comes to the clinic and shows you he still has the pain and he still is miserable. And you look at the picture looks perfect. You say, you must be crazy. This is so beautiful, and you're still complaining of pain, and you shove him to a pain guy who does all kinds of injections, finally a spinal cord stimulator, maybe a pain pump, a combo of all the things. He's got a pain pump here, he's got a spinal cord stimulator here, and on the top of it, he's getting a trigger point injections every clinical visit. Everything is CPT code oriented. So that was my main intention to bring this, and we are going a little bit more beyond this to present this data in the national meetings. So there, we see patients are smokers, patients are obese, patients are, all varieties are available. Can a patient come to your clinic and say, I'm having miserable pain, and then you look at the body structure, is obese, you reduce your body weight and come and see me after a year? It's advisable. Is it practical? The guy is big. He can't walk, he can't do anything with the pain. And you say exercise. The guy cannot even have a job. How can he have money to go to a gym? There's a lot of practical issues that needs to be addressed. Osteoporosis is very common. Trophic joints in the facets are very common with the things that we do. And those angles, you have done so many spine surgeries. You open, the spinolaminar angle is narrow, our facet is so trophic, almost abutting into the thecal side. And you'll be like hesitant to use a high-speed drill because this guy has gone through so many epidural steroid injections, And with the epidural steroid injection, the dural thecal sac is so thin. And then you touch it, you have a CSF leak. All these are things that you have seen. And still patients come with a lot of issues related to the spinal canal. And diagnostically, you can do an MRI that shows foraminal stenosis, you'll see spinal stenosis, and if you do a CAT scan, you'll see a ligamentum flavum that is hypertrophic. Now, it's like, what do I do now? You know, like, should I send him to a pain guy? Should I send him to a physical exercise? Or do a T10 to S1 fusion? Or do a segmental, whatever is the problem, just taking a good history and doing a good exam. So you send for exercise, you do all that kind of stuff. And then you sit at the table, you're still making a decision. There are tons of vendors who want to pour in, can you do this, can you do that? You know, you have tons of instrumentation available so that you have ideas, you've got some good things, some not good things. So it becomes a dilemma what to use. So that's why we thought that let's put things together and see what's going on. So we have selected the only the stenosis patients, and there were a lot of patients who had stenosis with stable spondylolisthesis, which I have not brought in here because we just wanted to present only the data with the spinal stenosis. So ideally, like, you know, this is about an instrumentation that we are talking about is a Coflex, which is an interlaminar fixation device. So ideally, you make a midline incision and then you go paraspinally and separate all the multifidus and all those muscles and go up to the facets, clean up everything. And then you have interspinous area that you open up. You see the ligamentum flavum, you excise the ligamentum flavum, and then fix this device with a interspinous interlaminar fixation device. And this is the technique from the company, how this procedure needs to be done. So basically you're seeing, you know, they've exposed the spinous process, they're going supraspinous, and then they work around the interspinous area and then remove all the interspinous ligament till they get down to the ligamentum flavum. And then they put the fixation device into the region. Is this adequate? Because the problem is, patient has stenosis. The stenosis, basic philosophy is stenosis is to decompress. What you do in terms of fixation is prevention of further complication that can arise after you take off all the elements that are playing in the spinal canal. So you can see that there's a foraminal stenosis in this region. And I definitely go beyond, you know, we initially used to do, like, you know, a solid decompression. And then we try to put a fixation device, then the spinous process won't break because you don't have much spinous process. And if you don't do, then you have not decompressed enough. And if you don't take the facet out, you can decompress it as much as you require. So all these were coming in my mind, how do I do the best to my patients? So look at this. I've taken the ligamentum flavum completely, and you can see the nerve exiting out. So I've done the foraminotomy, I've done the vasectomy, I've done the spinal decompression, and then I put the device, I just cover the thecal sac with a gel foam, and then put the interspinous interlaminar device to fix it. Now, in order to do this, you have to have certain idea that, you know, at least on the side where the problem is, decompress as max as you can. But on the contralateral side, preserve the joint capsule so that, you know, you can't, the spinous process will not break then. You have a solid stability on one side with which you can distract and then put the interspinous ligamentous interlaminar fixation device. With this, we have analyzed, I've been doing Coflex for 2.5 years now, and we have enrolled so many patients in this. And with this, we have seen, I've never brought a patient back to do further decompression. I've never taken up the Coflex that I have put in. I have taken up lots of Coflex put in by rehabilitation doctors, put in by the anesthesia, pain guys. All this, everybody, because there is a CPT code, everybody wants to be a surgeon. We go through 7 years of neurosurgery, or 5 years of orthopedics, and 2 years of fellowships in spine to do what we do. And those guys come out and they want to be surgeons. So this is where I think we guys have to really intervene and see how things have to be changed, and surgeons should remain as a surgeon, and everybody cannot become a surgeon unless otherwise they go through the training. So those, I know there's a lot of lobbying required and all this, but I think we have to do this, otherwise neurosurgery and orthopedic spine surgery will be taken away by pain guys. And they will be doing everything that you don't want them to do, and then you'll be dealing with all the complications that they do. So it's just a mind-opening talk I thought I should present, and I'm really going to put things together more and more in the national level. So thank you very much for the opportunity.
Are there any questions from the audience? Jeff?
So going back years ago, they came out initially with the Edge Stop, which was the first true intraspinous process spacer. And those of us who put them in, they realized it didn't work, didn't last, or rode the bone, whatever. We took out as many as we put in. Now Boston Sci has Vertiflex. So a lot of the pain doctors are doing Vertiflex. I can tell you where I am. There's no pain doctors doing Coflex, okay? Because, like yourself, to me, if you're going to put it in Coflex, the right way of doing it is to also do the decompression that's warranted.
Right.
And quite honestly, I think there is no role whatsoever for a physiatrist to be doing a decompression of the spine. It's bad enough that they use the mild procedure to percutaneous decompression.
Right.
You know, and that procedure has its issues as well. But I do see a considerable amount of pain doctors trying to do things that the surgeons normally do. I mean, as a neurosurgeon, we gave away our practices to the ortho-spine guys years ago. We gave away our vascular practice to the interventional radiologist.
Right.
So now we're trying to get all this stuff back as a neurosurgeon. You know, so to be giving it away now to the pain doctors and the physiatrists is
Right.
It's frightening, and it's the wrong thing to do. But yes, you're 100% correct. And that, you know, there was a guy in Northern New Jersey who was putting in pedicle screws, who was a pain doctor. You know, where he got the permission to do it or why they let him do it, I have no clue.
Yeah.
You know, I think it's up to the physicians to speak to the hospitals and the surgery centers and say, listen, I think they're really overstepping their bounds.
Yeah.
And it's not good patient care, and that's the thing. It has nothing to do with CPT code. For their purpose, yes, they want to be surgeons, but they're not.
Right.
But I see it.
Thank you.
What percentage of the just laminectomy patients still want for a reoperation?
It depends upon the number of levels that have been performed, and depends upon how much decompression has been done. We see a lot of people who go through laminectomy just up to %. Nerves are not decompressed, lateral recess is not even open. So there are many people doing many ways, and you know that becomes a hurdle for you when you go back to do the laminectomy. You're working through a scar, and you feel like there may be a CSF leak somewhere. It's not really a problem to have a CSF leak and then repairing the CSF leak, but it's just a pain to go through. When you're operating somebody else's problem and fixing their problem, and then re-laminectomies are basically a bad job done by my colleagues. That's why the problems.
So, but other countries like Sweden and other Scandinavian countries have argued in earlier studies that would be the justification for doing a fusion concurrently with the
fusions are, I agree with the fusions, but again, it depends upon like how much facets are you taking, and say like, you know, if you have a wide canal, even if you do 50% facetectomy, you're okay. You can still live with it. But if the canal is narrow, because if the spinal laminar angle is narrow, if the trophic, the joints are there, then you're removing so much, then you know it's justifiable to do the fusion.
And lastly, do you have BMI limits on your surgery patients that you do? Because it's a growing thing in
BMI,
right? My partner wants perfect outcomes. He clamps his BMIs to under 35. I personally think we're condemning a patient population to misery by limiting BMIs for the same reasons that you had mentioned. They're not going to be able to do the exercise. They have pain limitations. It's something that I think they just deserve a total knee so they can exercise. Not just you, but as our spine surgeons in general do lower complication rates.
Ideally, yes, 35 is the beautiful number, but I personally do for anybody and everybody as long as it fits on the table. The only thing that I hesitate to operate is a patient who smokes. And I tell them that, you know, this is something cultivated habit. If you can't give it up, you should be with me. I mean, you can stop it. I do the routine nicotine test, 15 days interval. From the day, I know it's difficult to call cold turkey today, I just stop it, but you know, take a day, 3, doesn't matter. But from the day you stop, I need you to have 15 days interval, 2 urine tests, and it was negative, and with a promise that you are going to stick with it for 1 year. You come and see me, otherwise I don't. Obesity, I have a little bit more compassion for obese people because it's just that they can't help themselves. And they don't want, nobody wants them. I'm a solo practitioner, and you know, like they go to the university, they get rejected. They go to somebody who are like the top neurosurgeons, top guys in the country, in the state. They don't want to see these guys because they're worried about their complication direction. But I don't. I take it. I do them. I very diligent in cleaning and making sure that it's the sterile area where I operate. I'm very, very clean about all this, but my heart feels for obese people, and I take care of them.
I have a couple of questions. The first is, again, from an orthopedic standpoint, this device that you showed us, the Bowflex device, we're putting a metal device in a mobile area, and there's no fusion there, obviously. The way I look at it, it's bound to fail no matter what. It's going to be metal fatigue, and the longer you follow up, that will invariably fail. So I don't know if that's the case. I don't know if previous devices have succeeded or failed in the long run, but I'm curious to know.
Right.
And my second question is to everybody who does spine surgery at large. And again, I'm an orthopedic guy. I don't do spines. So this is what I see all the time. You know, I see people who had phenomenal spinal surgery. You know, multi-level fusions, extensive hardware, perfect-looking X-rays, but they're all lining up at the pain.
Right.
If this sort of result happened for routine orthopedic surgery, 40% of our total joints failed and landed up at the pain clinic, we would be out of business.
Right.
You guys are still running strong. So what is the discrepancy between extensive surgery, which does not give you a good outcome, but you still keep doing the same thing over and over again? Why is it that in other aspects of orthopedic surgery, you look for a 90-95% success rate, whereas with spinal surgery, and I'm painting this with a very broad brush, your outcomes are certainly less than, it's like flipping a coin. So where is the discrepancy?
I mean, there are a couple of parts to your questions which I can address one by one.
Sure.
The first thing is the mobile segment, transitional segments, and fixed segments. Where in which, you know, like if a patient has got a T12 L1 stenosis, I'm not going to do a Coflex on that because it's a junctional segment. It requires a wide laminectomy and probably a fusion with pedicle screws. And because the T12 spinous process morphology is so different from the lumbar spinous process morphology. Same thing, same philosophy holds for me when I do the L5S1. L5S1 S1 sometimes it's like a stub, a little stub. You can't put the coflex because that wing is not going to hold it. And it's a weight-bearing thing that requires a lot more fixation than a coflex. So in that case, I take a primer lock, which is a clamp kind of a thing that can buttress and hold together so that there is no listhesis in L5S1 region. Between L2 to L5, coflex does a good job. Why do I use a coflex? And though it's not an arthrodesis in terms of real fixation, the very philosophy is to keep the mobility in that segment, which had made issues in the past with pedicle screws and rods that gives rise to the post-laminectomy syndrome and pain persisting. With this coflex, there's still mobility with the levels that we do, so that patients enjoys visual analog scale and the oscillator scale. You can see that there is I write only maximum 20 days of narcotics, that's it. And afterwards they're not asking me. I give my cell number to all my patients. They don't call me for pain because I make sure that these segments are taken care of. And this is the commonest segment where patients are having problems. So those are the philosophies of what do I do or what I do.
Using Dr. Sudhir's broad paintbrush again, not speaking to your practice.
Can't hear you.
I'm sorry, using Sudhir's broad paintbrush again and not specifically addressing your practice, what percentage of neurosurgical patients actually are involved in chronic pain clinics? I mean, we have a pain management guy in my practice and he's busy as stink. And almost 100% of his patients are in fact preoperative or a failed total knee. That's rare though, but almost all are back pain patients. And I honestly don't know what percentage underwent regional neurosurgical procedures or orthopedic spine procedures, but I just don't know the percentages. Because, and then the second part of that question is, what is the neurosurgeon doing to address postoperative pain in adjusting how they preoperatively plan or intraoperatively execute a procedure?
The thing is, first of all this instrumentation that we are using is like less than 5-year time frame where in which we cannot say like on a long term how they are going to behave. So it's just a short term study of 2 to 2.5 years. We got people whom we have done. And again, there is so many modifications of as Dr. Cristian was saying, there are so many tools have come and gone in the market. So we have been like trying this, trying that, and finally figuring it out what is the best one to use. So like yesterday he presented about the tops. So it's like, is that the best? So again, these are all going through a study period of seeing what is good.
But we're looking at mechanical outcomes.
Mechanically, yeah.
But is anybody actually measuring pain outcomes, long-term pain outcomes? I don't know the answer to that.
We have 1 year analysis on this where in the analog scale is like, they are really doing well, and I'm not prescribing any pain medication and they're not seeing any other pain guys for any injections or narcotics or anything. But again, there are two behavioral patterns. There are some people whom you can never satisfy what you do. There are certain people who are just addicted to pain medicines because they were given pain medications by others. So those are the kind of tough situations in which we go through. But if it's a pure stenotic patient with a claudication, you do this surgery, patients do not need any narcotics. If they are auto accident patients, manipulative patients, you got them. You're not the only person who is being abused, everybody is being abused.
Addressing the CPT guided influences on spine surgery, my ex-partner would operate on that podium if it had commercial insurance.
David knows the answer.
So that does aggravate and inflate postoperative pain scores in studies, right? well, what are the influences or the differences rather between surgical outcomes in Scandinavian socialized medicine countries versus the United States? And are there differences in surgical incidences in Appalachian, West Virginia versus the DC area?
I know Dr. Sudhir also comes from India. We never prescribe narcotics in India. Never. It's only the post-operative first few days they would get some pain medication, some narcotic in the hospital, but never ever gave a prescription for any narcotics outside the hospital. America is a totally different country. It's driven by so many people for so many reasons. It's very difficult for me to say that this is bad, that's bad, but by the time they see us, they are already been abused by so many systems of doctors and so many types of people for very, very many reasons. And then we have to, it's like, we are marrying this after a long time of being abused by others.
I'm not sure I buy that. I don't think that 100% of your patients are abused by general orthopedists or family doctors. Certainly some people get to neurosurgery from the ER directly, primarily, and I still see those patients in my pain clinic, right? So I think you're trying to absolve, not you personally again, but neurosurgical responsibility in contributing to that. I think that there are differences in countries and how we approach things, and is that the question to you is, not for your practice again, but is that being looked at? Because there may be cultural differences between India and North America, but there's probably less cultural differences between Western Europe and the United States. The differences being that in Scandinavian countries, for example, referencing my old readings about Malcolmson, there is a lower incidence to do surgery for the same trauma than there is in the United States. And several of my ex-partners have proven that to me, demonstrated that to me. And I see problems from early to ninth and late to peak management issues. Not necessarily in your experience, but does anybody know that are there differences between regional differences?
See, I did my fellowship in Cambridge, England. I was in the NHS kind of a medical system for 2.5 years, both in Oswestry and in London. So I know we didn't do so many fusions there, but here we do lots of fusions. It's very difficult to say why this is necessary here, why that's not necessary there. It comes to the dollar cents equation. I think in NHS doesn't want to spend money. So the Scandinavian countries may not spend so much money on fusion, the instrumentation, and America spends a lot more on the instrumentation.
That was the basis of my question, sorry. That, there's no question that in the US, the fusion rates across the board are several times higher than even Canada, right across the board. My question was that despite doing extensive instrumentation and the latest techniques or the old techniques, the outcomes are still less than desired. And that was my question, that we're still doing all these things, but then the pain clinics are still full of patients with failed spinal surgery. And I'm not trying to, point fingers at anyone. I was just trying to say that if this is the outcome, where the third or half the patients are back in the pain clinic, something is not right. And you can't hold the same standard to other orthopedic procedures where if half my total joints failed, I would not be doing that operation. That's all I'm trying to say. Any further questions?
But to answer your question, about 30 years ago, my wife first started her pain practice. She wanted to learn from top people. So she dragged me over to Amsterdam where Menno Schleuder, who was like the father of radial frequency. And we spent a week or so with Menno. She's talking to him one day, he's doing all the procedures. There's one patient who didn't show up, my wife mentioned that she had a little back pain. He goes, why don't you lie here on the table? Eli's not taking his little Novocaine, puts in 10 needles, and does needle branch rhizolysis, right? 5 levels both sides, local anesthesia. She was sore the next day. So after doing that, now we come back to the States. I'm in the pain clinic at the hospital. I had a bunch of patients that day, and they're ready to give them the Versed and the, you know, fentanyl, whatever else they were giving them. I said, you don't need that, because when I just came back from Amsterdam, these people were doing under local anesthesia. So that day, I started to remember going to local. You know, my wife gets a call from my nurse over there. She goes, Dr. Adler, you got to speak to your husband. She goes, the patients are irate today because nobody's getting the sedation that they come in for. You know, the mindset was that they're going to be sedated comfortably, and the fact that I thought, you know, they don't really need it. We can just do this little local. That's this population here. So that's part of the problem as well.
That's the cultural difference, right?
Yeah.
Thank you, Dr. Mohan. Our next speaker is going to teach us about the role of TXA in the management of chronic subdural hematomas. Dr. Quater, can I pronounce your name?
Yes, good morning to everyone. After all those spine talk, we're gonna talk a little bit about brain. So my background is neurosurgery with neuro-oncology training. I did medical neuro-oncology and orthosurgical neuro-oncology. I did a lot of brain tumors and radiosurgery. I'm a student of spine surgery. So I'm going to talk about the role of tranexamic acid in the management of chronic subdural hematoma. I have no disclosures. So chronic subdural hematoma is a liquefied hematoma in the subdural space with a characteristic outer membrane, and normally occurring about 3 weeks after head injury. This is a graphic showing the simple subdural hematoma with the layering effect and a characteristic thick outer membrane and a thinner inner membrane here. On the other hand, a complicated subdural hematoma will show a lot of these septations and also a combination of acute and chronic blood. And there are certain things that can make one get an increased risk of subdural hematoma. So as we all know, increasing age, because as we grow older, we lose some of our brain atrophy, and you have more tension of your cortical veins, and this can lead to small amount of bleeding in the subdural space, and leading to chronic subdural hematoma. Alcohol consumption is also one factor, because sometimes if you get drunk, you pass out, hit your head, and that can lead to also subdural hematoma. Male sex, use of antithrombotics, patients with brain atrophy, obviously Alzheimer's disease, dialysis patients, those patients who are both BP shunting, which can present with overdrainage, LP, or any surgery in the spine which can cause neurotomy, can also make patient prone to developing CSDH. So the anatomy is that the subdural space is actually a potential space, and as we see here, the dura mater is separated from the arachnoid with this dural border cells. The dural border cells actually is devoid of any collagen, so that will make it an easy or a natural cleavage where the fluid can actually separate the dura from the arachnoid. So that is the area which is a potential space that the hematoma can accumulate. So pathogenesis, basically, the most common cause is a minor inertial brain injury causing movement in the skull that tears the bridging vein. This can in turn result to the acute subdural hematoma, which can over time become chronic, and in response to cytokines there's proliferation of collagen and angiogenesis resulting to fibrinolysis and the expansion of the clot. Also, patients with chronic hygroma sometimes can develop microhemorrhages, and this can over time also lead to formation or of a chronic subdural hematoma. So this will show you the area where we have the hemorrhage, and you can see there that the durable cells actually is the potential space that you can have the hematoma, and the injury actually splits the durable cell, and then that can lead to inflammation resulting to coagulation problems and fibrinolysis, and also it can result to angiogenesis and vascular leakage leading to repeated episodes of bleeding and expansion of the hematoma, which normally becomes worse after 3 to 4 weeks and leading to chronic subdural hematoma. So the presentation can be heterogeneous. Patients can present with headaches, speech problems. They can present with some weakness or paralysis, cognitive decline, and also confusion. Majority of cases, history of trauma can be elicited, but for some patients, sometimes you ask them before the surgery, have you had a history of trauma? They cannot recall. Then after the surgery, they feel better, their brain is decompressed. Now they remember that, yeah, I hit my head before, like 4 weeks ago. About 22% of patients may be asymptomatic. 20% will have intake of anticoagulants. 30% will be on some aspirin. So the initial management of these patients, of course, you want to do some imaging, and the best way is to get a plain cranial CT scan, which is a fast and more accessible imaging that we can use. And depending on the age of the hematoma, it can present with certain densities. So acute, hyperacute hematoma can be isodense to the adjacent cortex. And day 1 to 2 post-injury, you can have the acute presentation, which is hyperdense to the compared to the brain. And beyond 3 days up to 21 days, it can be subacute in presentation, somewhere between isodense to the brain. And beyond 3 weeks, they now present with the classic hypodensity or hypodense collection, which we always see in chronic subdural hematoma. And sometimes patients only present with acute on top of chronic hematoma. We see some hyperdensity, and you see the layering and the hypodense component. So MRI can also be used, and there are different intensity based on the sequence that you will use. So typically T1, they're iso-intense to the CSF if there's activity, and they can also be hypo-intense if you see any active bleeding or rebleed. Flare is the best sequence to look at to make sure that what you see is not CSF. So it's basically hyper-intense to CSF on the MRI. And there can be some blooming on the GRE. Nakaguchi actually made a classification of the CT scan characteristics of the CSDH. We have here the homogeneous hypodense appearance, which is we clearly see in most patients. So you can see here there's a ripe subdural collection here. And the next slide would actually show the homogeneous isodense appearance. So sometimes it's hard to see where's the hematoma. So here you can see that you can see the sulci here on the left side. On the right side, you can barely see the sulci. So when I was a resident before, we normally would want to do my attending would say, maybe get a contrast CT scan, see if you can see the membrane. And the older attending before would always say, maybe Roy, we should get a angiogram, see if it's really being compressed. So, and then the trabeculated pattern can also be seen. These three CT scan up here have a lower chance of rebleeding, as opposed to the areas here down, which you can see the layering type of hematoma, and these are associated with much more increased risk of reaccumulation or re-expansion or reaccumulation after the surgical intervention. So predictors of recurrence of CSDH, it can be variable up to 26%. It's defined as an increase in the hematoma volume with neurologic problems. And it's basically seen in patients with brain atrophy, older patients, bilateral component of CSDH, alcoholism, and obese patients. Presence of thick membranes or septations, midline shift, poor expansion of the brain preoperatively, and pneumocystis can also be a predictor of recurrence of your CSDH. Intake of antithrombotics will not increase the recurrence rate. So when we do surgery for CSDH, so typically if it's 10 millimeter thickness with 5 millimeter midline shift, then you have to strongly consider doing surgery. If the thickness doesn't meet that, but patient will present with GCS9 or below, or decreasing neurologic dysfunction, you might have to consider doing surgery. So the techniques can be three techniques. We have a twisted craniostomy, which is done for patients who are in poor medical condition, patients who have a lot of comorbidities that we cannot do GA. So it's being done at bedside, do some twist, drill hole, and put a drain. But this type of procedure has a higher incidence of recurrence. What I normally do is a vertical craniostomy, which is I think the most efficient and most frequently performed. You can either do 1 or 2 burr holes. When I was in training, we only do 1 burr hole, but the idea is to, if it's a chronic subdural hematoma, I think the key is to make sure that you irrigate properly until the return flow is clear, and not to rush the irrigation. When I was a fellow in the hospital, I always do 2 burr holes. So when I came back and started doing 2 burr holes, my chairman would say, "Why are you doing 2 burr holes? You should only do 1 because you increase the complication rate with doing 2 burr holes." But I like the idea of actually looking into the irrigation. When you irrigate, you can observe the irrigation past beyond the 2nd burr hole. And then craniotomy can also be done. If it's more than 6 cm, it's a cranie. Less than 6 cm, it's a mini cranie. And these are normally done for patients with recurrent CSDH, for those with multiple membranes and with a lot of acute component, because we have acute component, it's basically probably difficult to evacuate that with simple irrigation and through a small burr hole. So in the meta-analysis, it has been shown that burr hole craniostomy results in best cure to complication ratio. Conservative management can also be used for patients who are at high risk for doing surgery, and those with not much symptoms, you can actually follow with serial CT scan. Patients who are moribund or who don't want to do surgery, you can choose to do conservative management. Now, one of the thing that I have used is the tranexamic acid. So it's a synthetic lysine analog, anticoagulative that blocks activation of plasminogen to plasmin via inhibition. The first case here reported was by Kageyama, and he used the drug for about mean average of 60 days, and in his study it has shown basically good response. So it can be given 750 milligram once a day, depending on which country. Here in the US, it's available at 650 milligram. Other countries, 250 and 500 milligram preparation. So it can be safely administered, seen in the CRUSH-2 and CRUSH-3 study. There are ongoing trials right now using TRACS and TORCs, where they use the tranexamic acid upfront treatment for CSDH, and also to prevent reaccumulation. And so the main issue with CSDH is that you have hyperfibrinolysis, which will lead to increased enlargement and liquefaction to CSDH. The idea is to intervene by addressing the issue. So we want to restrict fibrinolysis, and this can be done through medication called tranexamic acid. It can also decrease inflammation, and also it can be like an anti-angiogenesis drug. So I said earlier, you can do 650 in the US or 750 milligrams outside the US. Of course, there are adverse reactions. Seizures and myoclonus can be seen, 20% in myoclonus, some occlusion, and again, this is most important, the thromboembolic events, which can be a major problem. So, risk factors would be a higher dose, liver problem, older patients, history of cardiovascular disease, which make them prone to thrombosis, history or active thromboembolic disease, and use of concurrent agents. So what I normally do is I would like to request for a clearance from cardiology before I start the treatment. So this is a patient of mine back in maybe 3 years ago. He is a gentleman with history of hypertension, diabetes, and BPH. He's an intense guy, and he went to the ER and presented with left-sided weakness. And you can see the CT scan here showing the subacute hematoma on the right side with significant brain compression, significant mass effect in midline shift. So I did a 2 verbal craniotomy for this patient and clinically improved day 1 post-op. I don't normally do a CT scan post-op because it can create some confusion, especially with the neurology, we'll see some fluid collection post-op. But in this case, I think luckily it's good that they did a post-op CT scan. I was away, but the post-op CT scan actually showed improvement in terms of the hematoma size compared to pre-op. You have some hemocycles here, midline mass effects improved, and he was discharged. He was seen at the clinic day 11 with a slight increase in the hematoma formation here, maybe a big component here on the right frontal lobe. And then he came back day 17 post-op with increasing weakness on the left side and some headaches. So at this point, he was given some steroids, dexamethasone, and I had him start on the tranexamic acid, 500 milligrams every 8 hours. So his neuro status actually did not get worse. He was stable. Neurology wanted me to do surgery. I said we should probably just try doing the TXA. So the CT scan 2 days on the TXA, I would say probably almost stable at this time. Maybe the mass effect is a little bit improved. On day 7, the mass effect improved. Hematoma size is probably almost the same. At this point, I asked them to decrease the TXA to BID. And then 8 days later, we did a repeat CT scan, and there's remarkable improvement in the mass effect as well as the hematoma size. So here and here is smaller, even one there in the frontal pole there. And at this point, I asked him to decrease the TXA to once a day. And then I just followed the patient, and he was discharged. So we have these succeeding CT scans which over time showed improvement in the hematoma size as well as the mass effect. And sorry about this slide, I had it sent the MRI, the CT scan plates to me, I didn't get a good picture, but certainly you can see here that the mass effect is way improved compared to this one here, and the hematoma size is, I would say, completely resolved at this point. And this is another case, 58-year-old female with stroke cancer, with mediastinal cellulitis and COVID pneumonia, presenting with bilateral subdural fluid collection. And at this point, she was given some medical decompression, mannitol and dexamethasone, and then showed some progression of the hematoma posteriorly with some acute component there. And also, after 3 more days, showed, I think, increase in the fluid collection there. And at this point, she was diagnosed with COVID, started on tranexamic acid, 500 Q8, and 6 days later, the repeat CT scan showed improvement. At this point, they have stopped the TXA, and the repeat CT scan showed sustained improvement of the noted resolution here. And even at 2 weeks out. Problem with this patient is she went into respiratory failure from COVID pneumonia and then with PE, which may be related to the cancer or maybe from the TXA. This is a patient seen in the clinic. He had a history of fall, significant cardiac history. The initial CT scan, I would say, is okay. I think I saw him in the clinic. A repeat CT scan showed a small amount of subdural fluid collection here. And 2 weeks later, we had another CT scan which showed now a slight increase. I said at this point, we'll just not do anything. It's asymptomatic. We'll just do a repeat CT scan. And then after 3 to 4 weeks, there's an increase in the fluid collection here. So I said we should do tranexamic acid. And that I did for 1 month, and the repeat CT scan showed complete resolution of the hematoma. So, other options we can use is steroids, which can basically stabilize the membrane, prevent some edema. But we know that steroids has a long list of side effects that can present if you use it for a long time. Hyperglycemia, I think, is the most common complication. And it has been shown to reduce the recurrence rate and reduce hospital stay, but I would say probably we use the dexamethasone acutely, like in the acute process, maybe 1 or 2, 3 days presentation, and then not continue and maybe just use the TXA. Osmotherapy with mannitol is one option, but again, the issue is expansion of the hematoma, which can lead to further problem, and it's only, I think, given for patients who are actively perinating, like in-house deterioration, you can proceed to mannitol. Atorvastatin has been shown to be probably also effective in CSDH treatment. Again, it's also being given for radiation necrosis, so there are ongoing studies but no conclusion yet. ACE inhibitors, there's conflicting evidence on the use or its effectivity on CSDH. And we have seen this as an option also with meningeal embolization, which can be done by our endovascular neurosurgery. So they inject alcohol particles into the area, and this can prevent flow to the subdural hematoma. And there are ongoing trials for this one. The other approach from the inguinal or from the radial artery. So just to summarize, burr hole craniostomy is, I think, the preferred surgical method for CSDH treatment. If you have patients who are poor medical risk, maybe a twisted craniostomy can be done. Patients with significant membrane calcification should be addressed with, I would say, craniotomy. And single is as good as double burr hole craniostomy. And some would actually, instead of putting in a subdural drain, some would use a subruptural or subgatal drain, and they say it's probably almost the same. I typically don't put it like all the way into the subdural space. I only put it like just below the burr hole. And medical options can be an option for patients who are stable. Adjunctive therapy should be considered, like tranexamic acid. And for high-risk patients, because sometimes these patients need to be restarted on the anticoagulation. Sometimes you're stuck in a hard place and a rock, so I think for resuming anticoagulation, it can be resumed within 72 hours as long as you did a good job in terms of your decompression. I think that's my last slide.
Questions? I have one, doctor. If you had a patient with a history of PE or sedentary patient with cancer who's at high risk for the PE, would you ever consider topically applying the TXA?
Consider what?
Topically applying the TXA. You're washing out the dural space with saline. Would you consider washing it out with a TXA solution, a gram, 100 cc's or something?
No, I don't think it's been used for CSDH. Those have been used for ICH or intraventricular blood. That sometimes can be used.
It's something to think about.
Okay. Before pain pumps, before wound vacs came out, before the hand surgery that I do, I would use a pain pump and put an antibiotic solution and irrigate a wound with that. I mean, perhaps that's something you could do with a topical TXA solution through your burr hole and into a catheter for its topical application. Any other questions? Thank you very much. Our next talk this morning is going to be on the Basivertebral Nerve Ablation by Dr. Epstein.
Good morning. How many people are familiar with this procedure? Anybody doing them yet? It's just sort of ironic that it's goes along with the discussion we were having before about non-surgeons doing sort of surgical procedures. There was a day a couple months ago that in one of our local hospitals, they did 3 of these procedures in one day. One by an interventional radiologist, one by a neurosurgeon, and one by a pain doctor. So it crosses, you might say, different borders. I have nothing to disclose. So we're just going to talk generally about what is the basivertebral nerve, why are we lesioning and doing rhizolysis of it, the overview and the discussion itself. The problem I have with this talk is that I'm trying to keep it sort of non-industry, but there's really only one company that makes the equipment right now. So I'm not trying to be biased against them or for them, it's the fact of life right now. There'll be others, I'm sure, come along. But it's funny, I remember years ago standing here and giving a talk about sacroiliac joint fusions, and at the time there was only one company making the hardware. Now, of course, there's probably about 10 of them. So it depends when you hop on. We all have patients sort of like this. So for a long time we've been talking about the sinovertebral nerve or the basivertebral nerve. We know that it innervates the vertebral body itself. So the question is, what does it do, and how do we diagnose it, and how do we treat it? Years ago, again, this is more about the nerve itself and innervates the disc, but we always focus sort of like the disc is the culprit of the pain, or the subsequent problems such as stenosis, facet hypertrophy, et cetera, we never actually considered the vertebral body as the pain generator. But we're starting to see nowadays that, again, sort of opening our eyes, it's not that distinct from going back 10 years ago. Rarely would spine surgeons think about the sacroiliac joint as being the pain generator. But when you do a 4 or 5 level fusion in the lumbar area, sort of the next joint down in the body is the SI joint. So we start seeing SI joint pathology, start seeing hip pathology, because we're very fused to spine. What's next? So this is somewhat analogous to that. Dr. Modic first noticed changes in the, is there a, here, doohickey?
Yeah, there's a doohickey.
Thanks. So Dr. Modic first noted these changes, and he called them Modic changes. He didn't know what the significance was, but he wanted something named after himself. So he kept telling his residents, we'll find out one day what it means, but he knows he's early on. All these are evidence of Modic changes. Generally, we're familiar with the ones when we start seeing hyperintensity with the destructive disc itself, but all these, this is all early Modic changes, and all these theoretically can lend themselves to the treatment with the radiolisis for the procedure itself. We talk about Modic 1, Modic 2, those are the ones most familiar. If you're interested in this, like any good surgeon, you need to really see the studies yourself, because I can't tell you how many times we'll be looking at a study and the radiologist just doesn't mention any Modic changes, but you see it, and I don't think there's a good spine surgeon that doesn't see a film a week that the report misses something that you see with your own eyes. So obviously anybody who does surgery is going to review their own studies themselves and not count on the reports itself. Modic 3 is something I can't say that I've seen. Modic 1 and Modic 2, Modic 1 being sort of the classic, but we see these all the time. Again, you get it's hyperintense on T1 and hyperintense on T2. That's the standard Modic 1. As things progress, it becomes some 2 more Modic 2. You start getting some fatty infiltration into the area, disc space collapse, etc. But so what's the significance of this? Well, finally what happened is that people started finding that, gee, I have pain, I have pain when I bend forward, I have pain when I lift things, and you look at the rest of the spine, it doesn't look terrible, and the only thing you see is these type of changes. So we started saying, gee, what can we do about this? And that's when this whole procedure came around. Procedure itself is very easy to do. Anybody who has done kyphoplasty or vertebroplasty basically can do it with their eyes closed, which is why obviously pain doctors or everybody else can do it. But basically you're going to cannulate, and you want to be sort of posterior in the vertebral body, so if you want to be back here, that's where the main part of the nerve is. Very easy to cannulate. The hardware itself, the equipment we use, is a little bit of a pain in the rear end. Supposedly they're changing the hardware too, but it's a simple procedure, generally done under general anesthesia. There are some people doing it under locally. You can. It's just, for me, it's not worth it. One C-arm is enough, although some people do it using dual C-arms. I just think that makes it more difficult. You cannulate the area once you're in the right area. Basically, a 7-minute burn is all you need. And generally, of course, if you have motor changes, say, for example, at 4 or 5 or whatever, you're going to be doing L4 and L5. So what happens is that you'll go from one side of the patient, say, enter from the patient's right side into, for example, L4. Once you're in the right place, you start lesioning that. And so you then take a second set of hardware and enter into L5 from the patient's left side. So you're going like this, but the reason for doing that is as you're putting the hardware into the second level, you're already lesioning the first level. And again, it just cuts down the time. Very easy to do. Put a Band-Aid or a stereo strip over a little stab wound that you need to make. I tend to inject some local into the area just for post-op because I don't want patients complaining to me after they go that they have some discomfort. Overall, it's not a painful procedure. I'm not sure if my PAs give them any medication. They may give 2 or 3 days worth of something. I don't know. I leave it up to them, but I don't prescribe any medication. And they have a little discomfort. I say put an ice pack on, take some Motrin. That should be all you need. Pretty safe. It's been proven to be effective. And again, you just access the pedicle. This has a curve to it. After you take the probe itself out, you put it in the radiofrequency cannula, which has markings on it, and you just take an APB, make sure it's in the right place, and you plug it into the machine that they bring in. And that's the extent of it. This is the indications for the procedure itself. So chronic low back pain for at least 6 months duration. I mean, that sort of covers half the population, I find. Failure to respond to conservative treatment, MRI changes that show type 1 and type 2. For some reason, I don't know why when they first got the FDA approval for the procedure, they got it from L3 to S1. Of course, my first patient was an L2-3. So I put the probe in an L2, even though quoted wasn't approved. But to me, it's just stupid. If you have the changes there, you're symptomatic from the changes, you just do it. But again, theoretically, it's only for L3 to S1. Motor changes again, the inflammation for type 1 and the change in the vertebral body with marrow replacement for type 2. Nothing fancy about it. Contraindications. To me, the biggest problem is when there's instrumentation at a level. So I've seen post-op spine patients who have been fused and they happen to have, say they're fused from L2 to L4 and they have motor changes at 4 or 5. Well, you can easily get into the L5 vertebral body. Getting into L4, you can't get in following the same route because you have a pedicle screw in the area. So the discussion comes about what do you do with those patients? So either you can try an extrapendicular approach. They can be very difficult. I have personal experience. Or you just say, I'm sorry, we'll do one level and hope that you get some relief from it. If the patient is 100% fused, you can also offer the patient, gee, let me go in surgically and I'll remove your screws because as we all know, when we put in pedicle screws in the patient, they're only meant to be temporary until the bone fuses the bone. I don't know many people are doing it, but obviously some of the other problems, pregnancy, severe cardiac disease, etc., those are contraindications for doing the procedure itself. So these are the patients that we're seeing. Again, bending forward, lifting, those are called the sort of anterior column type pathology. So when you see patients who have this type of problem and they have motor changes, those are generally the patients that will be a good candidate for this procedure. Treatment algorithm, again, it's not rocket science. 6 months chronic low back pain, anterior versus posterior middle column disease. If it's anterior and they have the symptoms, go ahead and do it. Again, the right hand, you really have very little to lose. You tell the patient, hopefully it'll make you better, hopefully you'll get some relief. I can tell you, personally, I've been pretty happy with the procedure itself in the sense that the patients are finding that they are getting better. And they get better fairly quickly within a couple weeks or so. So I've been pretty happy with it. No complications, knock wood. So most of the clinical evidence overview, again, is published by Relievant, who's the company that makes the equipment itself. But there's enough that they stand behind it, and there's been a pretty good, robust journal articles about the procedure. ODIs have gotten better, as you can see, and this has been out for a few years now, and they seem to persist. If you see somebody that has pain, that comes back afterwards, the best thing to do probably is re-scan them, make sure they haven't developed motor changes at another level in the spine, which may be the cause. Because generally, if you do and you do it correctly, the procedure itself is not going to fail in the sense that if you're lesioning the sinovertebral nerve, basivertebral nerve, and that's the source of the pain, and they get better, then it sort of shows that, yes, you were doing the right thing. So when they come back, is it a different level that may be causing the problems or some other pathology? The VAS scales reduced quite nicely in all the studies that they have, which is nice to see. So, tips and suggestions. Again, take a look at the study itself. You know, you're going to see motor changes here, but you're also seeing motor changes here as well. So again, take a look at things. If you need to, you call the radiologist and say, hey doctor, if you ever give an addendum to your report, this way you have something in the patient's chart that says, yes, there are motor changes at that level, because a lot of times they'll mention other pathology, but they won't mention the motor changes. Again, the pain itself, imaging that goes along with it, the impression is the motor changes causing a specific back pain, and then the plan, of course, would be the BBN ablation. Postoperative care, there really is nothing, as I mentioned. I don't find that we need opioids on any of the patients so far that we've been operating upon. We tell them just to take it easy, but otherwise there's really no restrictions. I wouldn't say go out and play golf the next day. I'd say maybe wait a week, but aside from anything major, we haven't had any real problems. I just treat it just like you would treat almost any sort of pain type patient. You have an epidural, again, that type of thing. So that's how I deal with it. Thanks a lot. Any questions? I'm sorry.
Did the FDA approval or lack of it bother you, or just a reimbursement issue? Or?
No, the FDA, this is all FDA approved.
I mean for the upper level.
Yeah, I got paid for it.
Yeah.
Yeah.
Because I don't think FDA approval shy of reimbursement really matters. I mean, even the tranexamic acid is only FDA approved for nothing that anybody necessarily uses it for. It's for amenorrheic or hyperamenorrheic hemophilia.
Yeah. I mean, when I asked the people at the company, I said, why did you pick L3 to S1? And there was no good answer.
Have you found this to be temporary effect? I mean, is there like other formulations you see?
I can't tell you that's been temporary, because I haven't been doing it that long, but and unfortunately, a lot of these patients have multiple. What this is gee, is this somebody who may need a fusion? I guess maybe because of my training, I'm not a big fan of a lot of instrumentation. My wallet is, but me personally is not, and I think that's sometimes a sort of a bone of contention maybe between the ortho-spine guys and the neurosurgeons. We look at it as nerves with bone around it. They look at it as bone and gee, there's something in the hole in the center. Sorry for my ortho-spine friends, But again, it's something easy and simple to do. So if you think that may be a cause of part of the problem, you have very little to lose by trying it and see if it helps them. And if they get through their pain and they do well for even a few years, they're happy because you may have saved them a major operation, at least for a few years.
Oh, absolutely, especially those patients are poor surgical candidates in the role. They don't do anything to them. Especially
exactly.
It's so difficult to treat. That's great.
And there's no problem if somebody's on the chunky side, you got a chunky monkey, 350 pounds, it's not a big deal. So because obviously you're entering posterior, so that's why. So it's not a problem.
How many times you can burn the same one?
Yeah. I mean, because if you burned it here, you burned it, and it does not grow back. It's not like a medial branch, when you may have to do it every 6 months or a year or something like that.
And it's a radio frequency band.
Yes, it's sort of standard radio frequency. John?
I would suggest that the reason they authorized L3, somebody on the panel thought they remembered that someone told them that the spinal cord ends at L2.
T12L1. I thought, I don't know if that's the reason, but it should matter either way.
No,
Yeah.
I don't think it matters either.
Right.
No.
David?
Well, is this, somebody has also discogenic, or yeah, the discogenic issue here, is what you're treating. You also have somebody that has.
Well, I'm gonna stop you a second, because why is it discogenic? You know, it's vertebrogenic.
It's vertebrogenic.
I mean, we're both saying the same thing differently.
Right, and you also have the issue of essential neuropathy that you see on your MRI, and you also see your motor changes, your motor type 1, type 2. I haven't seen that many type 3s either.
No.
I've seen mainly the 1s and 2s in the films I reviewed. But, so, would you start out some type of progression here? We'll let you see, let's get an RFA first, and then after the RFA, then come to me, and I will see if there's no response to the RFA, then come in, and I'll do my procedure.
Well, I'll take it from a simple perspective.
Okay.
Okay? So I'll ask the patient to bend forward,
Shocking.
and I'll ask the patient to bend backwards. Okay? So if it hurts them going backwards, to me, that's posterior elements, like you said.
That's what
Okay?
right.
And if they go forward, they have pain, I go, aha, and motor change is fine, I'm going this way.
Right.
So I would start with that.
Okay.
You know, that doesn't mean that they don't have hypertrophy of the facets or thick ligament flum or spinal stenosis. But for what they're seeing before at the time, which is strictly back pain, no real leg pain, and pain leaning forward or picking something up, then that to me is this procedure.
Right, because I would call that if they have forward pain, I would say, we got discogenic pain, if we have backward pain, it's.
Mechanical back, facet, whatever, that's exactly.
Essentially,
So we're saying the same thing with different words.
Right.
Yes, exactly. So that's the key thing is what are their pain generators when they're moving? What can they do when they move? Does it hurt when they go forward? Does it hurt when they go backwards? You know, I mean, we see patients come in. You know, I mean, I love when they say, you know, oh, I can extend backwards. The first thing you see is the knees going like this. You know, the back's not moving, but the knees are bending. That's how they extend backwards. You know. Thank you.
Thank you. Our next talk today is going to be the approach to the Orthopaedic IME, what science says, by Dr. David Weiss.
Good morning, I'm David Weiss, I'm an orthopod, and I have no disclosure on this today. What I'm going to talk about today is how to perform a quality independent medical evaluation and the key concepts in performing the evaluation. And many of you will transition in your later years to performing independent medical evaluations. Some are probably already performing them now. And there's many avenues to performing the IME. You can do it through AMA impairment ratings, which is national. You can do pension exams, which are, in New Jersey, we call it accidental or ordinary injuries. You can do things on the federal level, which I started doing a year ago when you get the appointment as a federal referee in either neurosurgery or orthopedics. And of course, there's also out there the plethora of third-party IMEs, slip and fall IMEs, motor vehicle accident IMEs. The national average for the fee for performing IMEs, and I don't know the neurosurgical ones, I apologize for that, but the orthopedic ones now are anywhere from $1,500 up to $2,100 per IME now, nationally. The last survey was done around 2021. In court, the fees right now are running in orthopedics anywhere from $3,500 to $5,000 a day, spine surgeons such as Dr. Vaccaro or Rothman, they're commanding up to $10,000 to go to court and testify. So it is something to look at in your future as you progress. I started out early in my career doing it. I just liked forensic medicine. I liked the courtroom. I enjoyed it. And so for me, it became my major practice with my minor practice being my orthopedic practice. So we're going to get started here if I figure out how to do all this.
Up and down button, up and down.
Yeah, okay.
Bottom right.
Bottom right?
Yeah.
It's not, I'm doing the up down, it's not.
There you go. You got it.
Okay, so when I look at an IME, first thing I do is I think of two things. A, I'm going to solve a puzzle. A puzzle has many parts to it, and that's the first approach to doing the IME. The second approach also, which is very important to me, is I'm in the courtroom, I have to assume this case is going to triumph. How do I want to be perceived and how do I want to organize myself? And I find that if you pretend when you see the case and you're going to do the IME, that you start with that concept that, hey, I may have to testify in this case. I better not give net opinions that aren't backed up by science. There are several books out now on performing IMEs. One of them I have out there for the people if they want them to take afterwards. I have no financial interest in the book. The other aspect is there is a textbook out now called The Injury Causation Guidelines by Melbourne, 2nd edition, published by the AMA Press. We call it the Blue Book. And actually, this is the book I use in my federal cases. Because in the federal cases, they don't teach us how to go to judge school. We just have to examine the patient and write a federal opinion based upon legalese and medical knowledge. So giving that opinions, while that used to be acceptable years going by in the courtroom, you're going to get hammered really bad. So you got to base your report on what the medical literature is. Most of you here are, you can tell, medical junkies anyway, so journal junkies as we call it, so you'll understand what I'm talking about. So the key concepts are the history, the chief complaints, and the effect on ADLs, and now we've moved on from ADLs to talking about PROMIS studies. How many of you are familiar with what the PROMIS concept is? Okay. The PROMIS stands for Patient Reported Outcome Measurement Instrumentation. The AMA Guide, 6th edition, published in 2008, said that when you do an IME, you're required to do outcome measurement studies as part of your IME. In fact, last week in the JBJS, there was an article published by the AOA, the American Orthopaedic Association, that now says even when you see patients on the first office visit, this is not IME cases, you should be getting PROMIS studies on the first visit. So I'll show you some examples of the PROMIS studies. So the record review, including imaging studies, and the discussion and conclusion. It's very important that you review the images. In your treating patients, I know in my practice, and I know as Jeff says, we all review imaging studies. Not that we don't trust the neuroradiologists, they're wonderful people, but as orthopods and as neurosurgeons, you should review these studies. In New Jersey, you cannot do an IME and give a conclusion as to whether there's a herniated disc or not unless you have personally reviewed the films. You will be barred in New Jersey from giving an opinion just based upon your review of the IME report, of the imaging report. So practice pearls. So what we're going to talk about is called the longitudinal history. It's important that you get an idea in an acute claim or a motor vehicle accident, how this person hurt themselves. Was it a rear end hit? If the patient is coming in and saying, well, my knee hurts after the accident, okay, tell me how you hurt your knee. I don't remember. That's not good enough. You know, if you're claiming you got a patellofemoral pain syndrome from a direct impact injury, I have to hear that from you. I have to know that that's what happened to you. If you're not going to tell me what's going on, I'm going to exclude it from the report. Occupational disease and musculoskeletal disorders. Okay, there is a lot going on with what we call cumulative repetitive trauma disorder or occupational injuries. Anywheres from neck, low back, knees, shoulders, elbows with lateral medial epicondylitis issues, carpal tunnel syndromes, all these issues that we get. What bothers me sometimes is I'll have attorneys send me a claim petition from, in New Jersey cases, where they're claiming 9 or 10 body parts. And I try and tell the attorney, God didn't make them that way. I said, you just don't develop everything in your body is directly related. And then when you get the patient in the room, you say, all right, what is from your type of work, whatever you did on the assembly line? What did you do? Well, tell me how that affected your ankle joints. And I'll call the attorney up and say, hey, A is out, B is out. I said, it's line item veto in my practice. We veto it out. And generally, it's done even before I get to it. My orthopedic PAs that have been with me for 30, 35 years, I'll say, Dr. Weiss, this doesn't make sense anywhere. So we'll take it out. And we'll just tell the attorney, this is the report we're going to write. If you don't like it, I would advise you go get another doctor to do it. Get another orthopod, because I'm not going to be handling this for you this time. Okay. So the occupational, so you want to know a really good description of how this person developed a cumulative repetitive trauma disorder. Be it carpal tunnel, be it occupational low back syndrome, be it shoulder issues, be it knee issues. You need to get a good history, because you're going to get crossed on that. And you have sometimes acute on chronic, where the attorney will claim in an IME that, well, there's two issues here. There's an occupational claim, and then they also have an acute claim. So what you want to do here is kind of get it in your mind, where am I going with this as the doctor? Because remember again, and we'll be coming back to this, when you get on that witness stand, the attorney's sitting there, you're going to be up on that stand testifying. So you're the one that's going to have to back up your statements with basic facts. And we can skip toxicology here. Document treatment outcomes. How did the patient do after the treatments? Did you reviewed all these medical records? Did they get better? Did they get worse? Did they stay the same? Inconsistencies are very important. I look for inconsistencies in the medical records. You want to know that. Does the treating not follow? You know, the patient's claiming their neck. I look at the treatment records. I don't see any neck in the treating records. I'll say to the patient, did you injure your neck in the accident? I'll say, well, that's a no. So, and I don't see it in the medical records. It's out. And document the current status and plans to return to work. Again, you do want to know, you were injured in this car accident. Let's take a third-party case. How did you do? Did you go back to work right away? Or are you out of work now? And you have to realize something, and a lot of times, in most of these cases, you're dealing with litigation issues. Now, this is what we call PROMIS functional assessments. This is what we call the DASH, the Disability Arm, Shoulder, Hand Questionnaire. You have the stiff man's, what they call the stiff syndrome outcome after they've had a fusion. How did they do? And you have a PDQ questionnaire as well. The American Orthopaedic Association changed some of these guidelines now after this was written, but instead of the DASH now, we're going to specific shoulder outcome measurement. For the knees now, instead of the LEASH, the lower extremity activity scale, we're using the COAS or the knee outcome measurement scale. We still are using the PDQ, the pain disability, and we're still using a Roland Morris. All these forms are readily available to you. If you don't have them, or if you can't get them, you can call me in my office and I'll have my PA send you out all the forms so you'll have it to do. the conduct. This is really important. I can't tell you how many times I'll see, unfortunately, a doctor put in his own opinions into a report about the patient, has nothing to do with the case. The doctor will say, I think this patient's a liar. That's not for you to decide. You're there to decide orthopedic issues. Whether the patient's lying to you or not has nothing to do. This patient comes in today, he is obviously symptom magnifying. Well, that was good up until 2008 when the AMA 6th edition came out and said from now on, you cannot use Waddell's testing for symptom magnification in people that are either Asian or Hispanic, because when Gordon Waddell in the late 80s and early 90s published his studies of Waddell's signs for symptom magnification, it was done only on Anglos. There was no Hispanics done, and there was no Asians done. Ergo, you cannot say because this patient can't speak English and can't relate to you, he's symptom magnifying. It doesn't work. And one of the key concepts I do when I'm looking at IME reports on the Fed level is to see where this doctor's going with his report, and you can tell that. And I say, he's not allowed to say this in the report. He's not allowed to profile a patient that's Hispanic. And this was in 2008, it goes before diversity training, it goes before I was appointed the diversity chairman yesterday for us. Aggravation. I want to talk a little bit about the science of this. How many here know the difference between aggravation and exacerbation? The aggravation means that if you picture it in your mind, you're at a baseline before the injury. After the injury, you go up to a certain level. You never come back to that baseline again. That's an aggravation under the guidelines. That means that whatever you had prior, it got worse and became permanent. Exacerbation means, in case I just had, the patient had a total knee replacement 6 months before the new accident. Now they're claiming the new accident hurt the injury. So I said to the patients, well, what did they do? Did your doctor get a new MRI of your knee? Did you get an injection for the knee? Was there any discussion that you had a loosening of the hardware? So you look at the records, there's nothing in there. The patient got 2 weeks of physical therapy. That's a minor exacerbation. It doesn't fulfill criteria for aggravation. This is a good question that comes up on the IME exams multiple times. Does trauma aggravate degenerative joint or disc disease or arthritis? Did you have a real adverse effect or altered the course of progression of pre-existing degenerative joint disease and disc disease? The 6th edition addresses it. It says the increase in degenerative joint and disc disease symptoms, signs, and impairment never returns to the baseline. The answer is yes. Trauma can aggravate pre-existing asymptomatic degenerative joint disease and or arthritis. It's clear cut. So what Melbourne says, and that's in the AMA Guides to Injury Causation, when a compensable injury or exposure causes a new condition, there is no apportionment of subsequent evaluation and treatment. Generally, apportionment is not warranted when a pre-existing asymptomatic, untreated condition is rendered symptomatic and now requires evaluation and treatment. This is pretty basic. In other words, were you ever treated before for your knee before this accident? Were you ever treated before for your low back before the accident? Was there ever an MRI done of your knee before the accident? Was there ever an MRI done for your low back before the accident? Now you have the MRI, and Jeff is looking at the films, and he says, wow, the patient has motor 1 and motor type 2 changes. Okay. Now, we can all agree that was there before the accident. The changes on the T2 images that show that there's degenerative disc disease there before the accident. However, was there ever an MRI done before the accident? No. Were you ever treated before the accident? No. Ergo, now after the accident, either work-related or the third-party issue, now the claimant is injured. So now it's an aggravation of pre-existing degenerative disc disease, and if you find the motor changes, you can say also osteoarthritis of the spine. You'd be surprised how many doctors I see write reports that say, irregardless of this accident, this patient would have been here at this time. And the classic answer in the courtroom is, doctor, can you tell me what crystal ball you used to make this statement? Because I want to go out and buy that same crystal ball and then buy 100 lottery tickets based on that. Because you can't make that statement. The patient has degenerative hip disease. The patient ends up, after the accident, going to get a total hip replacement. Doctor says, well, it's all degenerative. I looked at it, there's some narrowing in the space. He would have had to have this joint replacement irregardless of the accident. That's a great statement. Show me the medical literature that can back you up. Show me. He can't. He's doing what the insurance company is asking him to do. So, an example of the science is the patient has arthroscopic surgery to the left knee. They get a meniscectomy and maybe a chondroplasty. Okay, 6 months goes by, the patient now complains, oh, my opposite right knee is hurting me now. And then the attorney files a claim for what we call altered body mechanics. Sounds like a great terminology. Everybody's on board, except it's not true. There's a study done by Harrington out of Ontario that refutes this case on several reasons. There's no evidence that suggests an injury to one's lower extremity would have any significant impact on opposite uninjured limbs unless the injury resulted in major muscle and nerve damage, causing a partial or complete paralysis or damaged leg or shortening. Then you have something to talk about. Then if you want to say, oh, he's had this amazing traumatic injury, we're going to include the opposite leg. Then you might get away with it. Or over time. 6 months is not time. If it's 2 years down the road, 3 years down the road, because most of the orthopods know the first thing you do when you have a knee injury, you shorten your stance. If you shorten your stance and your gait, how are you going to develop an altered body mechanic to the hip, I see it all. They'll claim the hip, they'll claim the knee, whatever. So those are the important things. So again, never give an opinion based upon what either the attorney wants or what the claim adjuster wants. Give the opinion based upon what you see and what you do, so you can sleep at night when you do these things. And then you'll be doing the quality evaluation. And another aspect is that the AMA has come out and said, and it's also in the ABIME, if you have a patient and it's sent back to you by the insurance company or by an attorney, and they want you to give an opinion on need for treatment. I don't know how many of the neurosurgeons do need for treatment evals. In orthopedics, it's done a lot. You can't do a need for treatment IME on a patient that you've treated. It's in violation of the American Board of Independent Medical Examiners. It's in violation of the ABMS board in orthopedics. And in New Jersey, if you give an adverse opinion on a patient that you treated and try and come out and say, well, this was an IME, you'll be sanctioned by the State Board of Medical Examiners in New Jersey for giving that type of opinion, unless you tell the patient in writing and verbally, I am giving an adverse opinion on you today. So you can't do that. So be honest in what you're doing. I'll take questions if there's any questions on it. Yes?
What is your interpretation of your legal liability in third-party cases where you do an IME? Because physically examining a patient requires their permission, or else it's an assault.
I have a form that every patient fills out before they get from the waiting room in to see us. and explains you are here today on behalf of or whoever this, that's ordered there is no physician-patient relationship established. If anything that I ask you to do bothers you, stop. Don't do that part of the exam. If I tell the patient I'm going to do straight leg raising, sitting root, and it bothers you, don't do it. But I'll put down this was not performed as per the patient. We'll put that in the exam. There is no, you do have to tell your carrier you are going to be doing IMEs. You should tell your carrier that. Because some carriers say, well, I don't know if we're going to cover you for, I don't know, But the aspect is, the rate of lawsuits for an IME are almost negligible. As long as you don't go out there and be disparaging to the patient during your exam, and you treat the patient with respect that he deserves, and then you show compassion while you're doing the exam, you'll be all right. And if it's a female patient, I always bring in one of my PAs to be there and watch and document. Because nowadays, patients come in and say, well, I'm going to record our IME. And they do. We had a case that came up a few months ago where this doctor wrote a 3-page IME, examined every body part the patient had the tape on. The doctor sat down, the patient walked in the room, said, let me see you walk on your heels, let me see you walk on your toes, bend over, great, go to the side, great, you're done. Wrote a whole report. Had another doctor that I was up against who did a whole report, and I said to my attorney, I said, it's interesting that he did this whole exam, didn't note that there was carpal tunnel surgery, didn't note that there was shoulder surgery, but yet said he examined the shoulder and the wrist and they were completely normal. So when he got crossed on it, he got angry on the stand, started yelling at the attorney and had to be calmed down because he realized he had been thought out here, that he really was, faking the exams. So yeah, there is no liability. The liability is negligible, but you have to make them sign these forms, or you don't see them. If they don't sign the forms, I would not examine. I tell the patient, I'm sorry, I can't do the exam today. It's your choice. That's what I tell them.
When you mentioned disbarment for making opinions about science and proof,
not disbarment, but if you don't go by the science when you're on the witness stand, you can be crossed on this. It's become very sophisticated now in forensics when you're on that stand now. And they'll be sitting down there with their articles. I can't tell you how many times I have to quote the Bowden studies from the JBJS in 1990 that talks about the number of asymptomatic herniated disc, asymptomatic bulging disc, asymptomatic degenerative disc, and the patient populations. I mean, it's amazing what the attorneys have gathered as to evidence, as to their textbook learning. So what I do at the end of my report, I give all my references. If it's a spine case, a lot of times I'll go through, and I see some soft tissue, I'll quote Janet Travell's textbook, Travell and Simons. I'll quote Viccaro's textbook a lot of times, core knowledge, and then of course the OKU books in the spine. That amazing 4, 5, 6 on whiplash-associated disorders from car crashes, the Schoferman studies. So it's all there because the orthopedics recognize whiplash-associated disorders, and they recognize the facet joint injuries. They give you the percentages. They'll talk about what percent get disc problems, what shoulder problems, what knee problems. It's all there in the OKU textbooks of the spine.
Speaking of textbooks, probably the worst written textbook in the history of medicine is the AMA 6th edition guide for disciplinary determination.
You sound like an attorney. I was teaching the course in Philadelphia. And one of the attorneys said that.
Well, it still may be.
He was plaintiff, of course.
But for the non-professional IME performer or the non-experienced one, it's an impossible textbook to guide you into being fair to a patient.
And you're right.
Right, and it's not even written by subspecialists in the area. For example, if you amputate the tip of your pinky finger and you're a carpenter or a plumber, your level of disability is far greater than somebody who's a cosmetologist with the same injury. Because you're losing a ton of power generation in your hand.
Right.
That'll give you less disability than if you, functionally, he'll lose have greater disability if he loses the tip of his pinky than if he loses his entire index finger, but that's not reflected in it.
No.
So functional outcomes are not really taken into consideration in the 6th edition.
And it's true. It's true because I know years back I had a case where the gentleman had 2-level fusion, had to have redos, and at that time in Pennsylvania, we have the system called the IRA Impairment Rating Examination. So I'm a certified orthopod with the state of Pennsylvania since 1996. And they had set the bar at 50%. Well, if you know the AMA guidelines, it's almost impossible to get 50%. So the gentleman that I did it on came out about 32% impairment with all this pathology, and he was on Social Security disability. So there I am, I'm in the middle of the deposition, and the plaintiff doctor says, Dr. Weiss, you gave this gentleman 35%. Yes. Can this patient work right now? I said, no. They said, doctor, the patient's on Social Security. I said, yeah. Doctor, you only gave him 35%. I said, I realize that. He says, do you think this is fair? I said, counselor, it's not for me to judge the fairness. What's fair is that this is his impairment rating based on the AMA guides that I have to go by from the state of Pennsylvania. They told me I have to do the exam. This is where it shows. This is where your guy is. And so eventually we lowered it about 6 years ago down to 35%. We were being benevolent. And the state lowered the impairment rating to 35. Well, guess what? If you had discitis and fusion, you would just be at 32% and not make the 35. That's a guy that gets a discitis, osteomyelitis, you're not going to make it. So the guides are, I don't understand, some of the things in the guides are impossible to comprehend.
Right.
But
it actually is unfair to patients. You can have a complete 100% median nerve transection coming to me chronically from a farm injury, totally insensate radial hand, and it's not 100% hand loss.
It's true.
Right. For a farm labor. So what's the role of a functional capacity evaluation in augmenting your FCE reports?
I do.
Empower.
Okay. When I do my pension exams in New Jersey, I used to be the pension examiner for the state. I came off in 14, and then instead of representing the state, I decided I'd rather represent the PBA and the police and fire. So I did. So when I do an exam now, I like to get a functional capacity on a police officer, a firefighter, or corrections officer. Because the two things that the functional capacity measures is tolerance and capacity. How you tolerate doing the FCE, and what does the FCE show your capacity towards doing the job. Now
and potentially validity.
Yeah, and the tolerance is a psychometric issue. The capacity is can you do your job as a police officer? It measures those parameters. Police officer has to lift over 100 pounds. He's got to be able to extricate an injured motorist. The police officer has to be able to climb a chain link fence. He has to be able to go after a suspect and effect arrest. So there's certain issues, and plus we get, the gun issues. Muscle control and shooting, being able to handle the weapons retention. Can I take the gun out of your hand? If I can, that's a bad issue. So if the FCE will clarify that issue for us. The other aspect is what we call, and what he's alluding to, is what we call the coefficient of variable ratios. In the FCE, it measures how you progress through doing a certain act. If you have a wide swing and you have a coefficient variable ratio over 13%, that they'll put down that so-and-so is not giving a valid response. He's not giving maximal effort, and they'll say that on the FCE. So you got to be careful with that, because if you have chronic back pain, and we've talked about this through the 2 days, if you have chronic back pain, and I tell you, you got to lift this 50 pounds here, mentally you're going to say, wow, that's going to make my back hurt. So you're going to block out your full effort. That could affect the FCE. So what I look at is the bottom line of the FCE. Does it say you can do it, or can't you do it? As to the issue of not giving a full effort or symptom magnifying, I'll make that decision while I'm examining you. If I see that you fulfill Waddell's criteria of symptomatic, I'll put that down. I'll put that down, that there is some symptom. Otherwise, I don't put it down at all. I stay away from that, because you shouldn't go to symptom magnifying now as a issue. You shouldn't put that on your report, no more than you say the patient is lying to me today. You know, have your own opinions as to the patient's veracity. You shouldn't be doing that on your IME. Take the history, review the records, look at the films, do your orthopedic exam, write your conclusions, and cite your cite your quotes, and leave it alone. Leave it alone. The rest you don't care about. You know, you may have a bias, but we all have biases in this world. You know, some people are biased towards the plaintiff, some people are biased towards the defense. That's okay, but you check your bias at the door when you do your IME. Any other questions?
Dr. Weiss, you mentioned about symptomatology and this Waddell's criteria. I'm not familiar with that, but you're not supposed to use race, or you're supposed to discount that, but you just don't talk about it.
I discount if it's Hispanic or Asian, I discount.
Well, the reason I bring this up, there's clearly a small subset of patients that I see, and all of us see, that have a hyper-exaggerated response.
Oh, no question about it.
Right. You know, you touch them and everything hurts.
Right.
You know that that is objectively.
Well, you use the word,
how do you describe it?
Let's say I examine a patient, I say, okay, we're going to do an O'Brien's test. Bring the arm across, and I'll do a straightforward O'Brien's test. And the patient says, well, that hurts me, my whole arm up. I'll put down, instead of the patient symptomatic, it was a global response in nature. So you phrase it in words that it tells what you're saying, you know? Or the gait, I call it Charlie Chaplin sign. You'll see the patient walk into your office, they'll have canes, they'll have crutches, or they'll have a walker. And then you watch them when they get out and get into their car, and they take the canes and the walker and they throw them in the backseat of the car. I call that the Charlie Chaplin sign. So, but you stay away, you just say their gait is it doesn't fit, it's not physiological. It's a non-physiological gait. Or the patient will come in and they'll walk like this with their arm like this, but yet you find no signs of complex regional pain syndrome. But yet they can't move their arm when you examine them. Non-physiological response. Get you right out of it. You just say, well, what do you mean by that?
But doesn't get you out of it. Sooner or later you're going to have to whittle down in front of somebody, whether it's in court or whether it's to the nurse case manager or to the employer. You're going to have to put it in lay terms and call bullshit on it. If that's what
you have to be careful what you say. This is a different world out there today. 10 years ago, they didn't record the doctors doing the IMEs. Now they do.
Can you say that patient symptoms cannot be explained based on objective physical
Yes,
findings?
you can say that. Couching it, and you can say that to the adjuster. Look, I cannot, based on my orthopedic exam and the review, my own review of the imaging studies and the medical records, say that this is what I'm seeing today. It's not.
So here's another thing I see all the time. You know, you've got this 55-year-old guy, you know, who steps in a hole, injures his knee, and then comes to you because he's not getting better.
Right.
And then he's got some age-appropriate arthritic changes, and they all come to you with an MRI. and they all have meniscal tears. They all have partial ACL signal changes.
Right, the signal changes,
Yeah.
attenuated ACL.
Yeah, and they all got a Baker's cyst. And they're the standard 55-year-old MRI scan. And now everything you see on that MRI is because he stepped into a hole, which and I know is not true.
Right.
How do you deal with that? Again,
Well,
it's one thing to treat the patient, it's another thing to treat the workman's comp situation.
Right. You have to go by what Melbourne says. I go back to Melbourne on that. And Melbourne says if the condition is asymptomatic and untreated, then it's been aggravated. You don't have to say, it's like sometimes what we call the new terminology is direct causation and or direct aggravation. In other words, just like that 55-year-old, if I do an MRI on the 55-year-old and I look at the T2 weighted image, I'm going to see that the discs are gray or dull or black. Now, that wasn't caused by the accident, but the guy has back pain. He's been to the interventional pain management specialist. He's had epidural blocks. He's had radio frequency blocks. And now, he may have found a spine or neurosurgeon that says, you know what, we need to do surgery here. And the situation is, well, doctor, is this injury related? Is this related? Is the surgery proposed by Dr. Epstein reasonable, necessary? Yes. Is it directly attributable to the accident? Now you got to make a call because Epstein's already put down he wants to do the surgery and he's wrote down that it's related to the accident. So now you have to make the call as the IME examiner whether or not. So I'll say, well, the surgery proposed by Dr. Epstein is reasonable and necessary. However, if I review the medical records and I see that he was treated for similar issues a year or two before, I don't give it to you then. Just like I won't give you an accidental pension if you got treated for the similar issue. But according to Melbourne, you have to go with that issue of the aggravation of an asymptomatic untreated.
And how long does an aggravation last before it becomes an exacerbation?
Well, the aggravation is permanent. It's the exacerbation that leaves you.
So how long does that last? How long, so your summary of Sudhir's patient would be, well, he aggravated his knee. Therefore, in 6 months, I'm going to declare him a maximal medical improvement, but not a full recovery, and we're terminating workers' compensation coverage at that point. How do you pick the time where an aggravation is completed itself?
Well, I just say, if I'm seeing him 6 months out, and I see the aggravation is there, if there's been nothing proposed, see, that gets into the idea of MMI. And the idea, how many people understand what maximum medical improvement is here when you use that phraseology? Okay. That means that no further conservative care is going to make better your condition. That's what MMI means. You're still allowed, even under the AMA, to get palliative care. It doesn't say you're not allowed to get the care. It just says that no further palliative care will make better your condition.
So an aggravating condition can then be treated indefinitely?
It can be treated, but the fact of the matter is, are you getting surgery for that condition? In other words, I look at it this way. You come in, Dr. Wells said, about this knee, and it shows a torn meniscus, and you may think it's degenerative because it's a complex tear. But the surgeon now wants to do surgery, the workers' comp surgeon wants to do surgery on it with a meniscectomy and maybe chondroplasty. Okay. I ask the patient, you're going to do the surgery, you schedule it. The patient says, no, I'm not scheduling, I don't intend to do the surgery. Guess what? You're at MMI. Because now, here's the second scenario. There's one more scenario. Patient comes in and says, I'm scheduled for epidural blocks next week. What do you do when you see that? Is the patient an MMI or not?
No.
They are. Because it's palliative. There's no literature out there that says an epidural block, radiofrequency ablation is going to cure a herniated disc, is going to cure a facet joint syndrome. So I write MMI. I say you're entitled to go get it. You can go get the epidural blocks, but it's not your MMI. Your choice is you either go back to work or go get an FCE, or whatever you want to do, but from my viewpoint, you have to go back to work.
So what would you do with the patient who has a mechanism of injury that doesn't account for, not stepping in a hole, but doesn't account for the injury? So I'm a plant doc for the Cummings Motor Company.
Right.
The worker's picking up a 4-pound carburetor. She does it repetitively, but she has a shoulder dislocation, has to go to the ER. Images show it's out anterior and you put it back in.
Right.
But 4 pounds doesn't dislocate a shoulder.
Now you got to look into literature. You have to look at the medical records. You want to get the medical records.
No history.
What?
No care history.
No care history.
No care history.
Then you got to.
Not rheumatoid.
You have to follow Melhorn then. You have to follow what Melhorn tells you on apportionment. The idea of apportionment also guides you in what you're thinking about. That's why I recommend that if you're going to do IMEs, have Melhorn. It's not an expensive book, but have it there so that you can look at all the studies that Melhorn quotes on these issues. Anything else out there? Thank you so much.
Thank you all for attending this session. It's over now.
This one guy that I had was a T12 impression and a T11 spinal process. Very elongated. Watching just jacked up truck. He did the same thing. Sticks in the back. He pulls himself up with his truck. The gap between the top of his tires and his roll is this much. Yeah. Yeah, so the right answer would be somebody trying to sell correction, right? Treating this. I've seen a lot of work in hospital, but I don't carry it. That's all. There was a patient might have scheduled trying to get it there. So she never went to work. She ended up having to flip on I can't drive this. I'm going to call her. So she just calls my phone's office. She